use your video because you got remote folks. So get your video on, audio off. Use the mic that's at your table. And hit the button, and we'll get going, and we'll make sure that the folks remotely are engaged in the conversation as much as the folks who are in the room. As you just heard, this meeting is being recorded, and it will be posted on the AHRQ website when it becomes available. There's also closed captioning available for the meeting. If you need closed captioning, go ahead and click on that the icon in the in your Zoom at the bottom of your screen. Let's take a look at the agenda. All right, so agenda for today, and welcome call to order. We'll look at our esteemed directors' highlights, and then we'll talk about quality in different care settings. We'll talk about private equity in healthcare. We'll have the standard public comment, and we'll wrap things up. So let's go into next slide. Yeah, let's go into so you can see there our 7 new members that are joining the NAC. So what we're going to do, given that one, we have a nice bolus here of new members, is we're actually going to go around the room and everyone's going to do a quick introduction, just so that the new members know who the returning members are and vice versa. Okay. So I'm going to start on my right, actually, and Krista, you can go first.
My name is Krista Hughes, and I'm from Birmingham, Alabama. I'm a board certified patient advocate and the founder and CEO of Hughes Advocacy and Passion for Patients. And I'm honored to be able to serve with the AHRQ and the National Council. Thank you.
Caroline, go ahead. You're on.
Good afternoon, everyone. I'm Dr. Caroline Carney. I am a board certified internist and psychiatrist. I serve as the president of Magellan Behavioral Health and the chief medical officer for all of Magellan Health, including our PBM, our specialty management organization, our federal organization, and our behavioral health organization. It's terrific to be here. This is my second meeting, so still feel pretty new. Welcome, everyone.
Hi, Neil Goldfarb, new member. I run the Greater Philadelphia Business Coalition on Health. So that's an employer purchaser coalition in southeastern Pennsylvania, Delaware, and southern New Jersey. And before starting the coalition 10 years ago, I spent 35 years as a researcher on quality and cost of care.
Hey, good day. Sherry Ling, Deputy Chief Medical Officer for the Centers for Medicare and Medicaid Services. Geriatrician, still practicing, an internist, and one of the ex officio representatives here, non-voting. Thanks.
Hello, everyone. My name is Komal Bajaj. I'm Chief Quality Officer at New York City Health and Hospitals, Jacoby and North Central Bronx, which are 2 facilities that are part of New York City Health and Hospitals, the municipal health system for New York City. I also serve as the clinical director for the System Simulation Program, and I'm a professor of obstetrics and gynecology at Albert Einstein College of Medicine. Glad to be here.
Hello, everyone. My name is Mai Pham. I'm a general internist and president and CEO of a nonprofit called Institute for Exceptional Care, focused on transforming healthcare for people with intellectual and developmental disabilities. And I was previously Chief Innovation Officer at the CMS Innovation Center and at Anthem, leading value-based payment efforts. Glad to be here.
Good morning and good afternoon, everyone. Kanan Ramar, I'm a new member. And I knew I shouldn't be doing that, so that's a good warning. And for others too. I'm a pulmonary critical care physician at Mayo Clinic in Rochester, Minnesota, and serve as the Chief Patient Safety Officer for Mayo Clinic. Thank you, and glad to be here.
Good afternoon. I'm Kathy Ivory. I'm a registered nurse and the Associate Nurse Executive for Practice at Vanderbilt University Medical Center in Nashville, Tennessee, and faculty member at the Vanderbilt University School of Nursing. Glad to be here.
Jia Zhang, I'm the Dean of the School of Biomedical Informatics at the University of Texas Health Science Center at Houston. My focus area is on using data science AI to improve safety, usability, and for health information technology. Thank you. It's my first time here.
Hi, I'm Mireille Jacobson. I'm a health economist based at the Davis School of Gerontology at the University of Southern California and the Shaper Center for Health Policy and Economics.
Hello, I'm Patrick Romano. I'm a general internist and a general pediatrician by training. I'm on faculty in the School of Medicine at the University of California, Davis, which is actually in Sacramento, California. And I work on developing, testing, validating, refining measures that are used in healthcare quality programs, particularly in the inpatient sector. But have a broad interest in AHRQ's activities and patient safety in particular.
Hello, good day, everyone. Gina Reyes. I am a registered nurse by background. I am the Director for Clinical Transformation and Quality at Horizon Blue Cross Blue Shield in New Jersey. I lead a team that works with practice transformation in value-based programs. Thank you.
Good afternoon, everyone. My name is Henry Tang. I'm currently the Senior Vice President and Chief Health and Wellbeing Officer at Delta Airlines. I'm a cardiologist and health services researcher by training and have previously been the Chief Value Officer at Mayo Clinic and the Chief Quality Officer at New York Presbyterian. Thank you.
And you're going to have some time to introduce yourself. I'm going to get those as well. So looking online, I think I saw Melinda. You want to jump on?
Sure. Yes. Good afternoon, everyone. I'm Melinda Benton. I'm a health economist and chair of the Department of Health Policy at Vanderbilt School of Medicine. I'm delighted to be here, coming back for my second year, I think, on the committee, and hope to make it in person before my term ends.
And I saw Susan. Yeah.
Yes. Hi. Can you hear me? Yep. Okay. I had trouble before. I'm Susan Edgman Levitan. I'm a family medicine PA, and I'm the director of the Mass General Stokel Center for Primary Care Innovation. And I also co-chair our Mass General Brigham Systems Patient Experience Leaders work. And I'm one of the 4 CAPS Consortium principal investigators.
Thanks, Susan. Asaf.
Hi, good afternoon. Good morning, everyone. Asaf Bitan. I'm Executive Director of Ariadne Labs. It's a Health Systems Innovation Center at Harvard T.H. Chan School of Public Health and Brigham and Women's Hospital, where I'm also a practicing primary care physician. I get a chance to work with Susan a lot, which is fantastic, and a number of other of you. I'm a senior policy advisor at CMMI around primary care payment and delivery. And I do a lot of global work on primary healthcare improvement and measurement through being the vice chair of the Primary Healthcare Performance Initiative, which is a global primary healthcare initiative. So happy to be here with you all.
Thank you, Asaf. Jadrika.
Good day, everyone. It's a pleasure to be here. My name is Joey Drika Brown Spates. I'm a family physician. I am professor and chair of family medicine and rural health at FSU College of Medicine. My interests are broad, but include health equity, especially in the maternal child health equity space, rural health, community engagement, and also global health. I just returned from Kenya, so I'm still living that experience of it, and very, very pleased to be here today.
Thank you. David Smits.
Hello, I'm David Schmitz. I'm a family physician, professor and chair of the Department of Family and Community Medicine at the University of North Dakota in Grand Forks. I also have a background in rural health, and I'm a prior president of the National Rural Health Association. And my academic emphasis has been on rural health care access, rural medical education, and workforce. I enjoyed this morning. I apologize, I won't be able to stay for the duration of the meeting because of a prior commitment also with HRSA here in Washington, DC.
Thanks, David. I thought I saw Young Ling on earlier. Maybe she dropped. So we'll get her back. And I think we have Michael Lauer from NIH. Yeah.
Hi, good afternoon. I'm Michael Lauer. I'm the ex officio member from the National Institutes of Health. I am the NIH Deputy Director for Extramural Research, and by background, I was a cardiologist and a clinical epidemiologist.
Thanks, Mike. And Lisa?
Hello, this is Liza Catucci. I'm actually a senior administrator, a long-term employee from the Department of Veterans Affairs and Veterans Health Administration. As of this week, I was detailed into the role of Acting Deputy Director for Health Services Research and Development. I'm representing Dr. Atkins, who's the director, who's unable to be here today, but I'm happy to be here in his place and looking forward to the meeting. Thank you.
50-50 chance of getting your name right. It's Lisa or Liza, and I missed it. Sorry. So yeah, on the Zooms, and again, we're kind of thanks everyone for your introductions. That's great, and we'll have more time to interact over the course of both this meeting and subsequent opportunities. Again, just kind of some Zoom etiquette here. There's also an opportunity for you all to kind of change your video settings depending on where you are, so that you can see everyone. You can see the speakers and so forth. So just kind of adjust your settings as you need to if you're remote, so you can see folks. A reminder for the public, right? So there is public comment, as I mentioned in the agenda. So if you do want to leave some public comment, you can see the notice here. The email National Advisory Council at ahrq.hhs.gov. Please send that email no later than 2:30 Eastern. And your comments should be limited to 3 minutes. So with that, let's get into the business. First order of business is approval of the minutes. So I'm sure you all have had a chance to review those minutes among all the other things that you reviewed in your pre-reads. So do we have, yes, you guys did send a lot of pre-reads, but we all are very good at managing that. Any comments or edits for the minutes from the last meeting? Hearing none, there's a motion to approve the minutes. Thank you, Caroline. Second.
Second.
Thank you, Krista. So moved in second. Anyone opposed? None. The minutes are approved. Let's go into the director's report. Oh, I'm sorry. Hold on. Oh, Yingling is on. Sorry, Yingling came back on. So let's get Yingling. We were doing introductions, and I was looking for you. So now that you're on, can you introduce yourself, please?
Yes, thank you. I can hear your voice, and I just cannot talk. But anyway, my name is Yanling Yu. I'm living in Seattle. I'm by training, I'm research scientist to study climate change, ocean circulation. But I'm now a full-time patient advocate. I'm with Washington Advocate for Patient Safety, and so glad to be here.
Thank you, Yingling. It's been great having you on the NAC. Now you can go to the director's report. I've been given approval to go to the director's report.
Thanks very much, Mundo. And first of all, thanks very much for all of you for joining us together today together. It's wonderful to have a full complement of a National Advisory Committee. At our last National Advisory Committee, we had a wonderful group, but we were a small contingent. And it was a small but mighty contingent, I must say. But as we try to move our work forward, I'm looking forward to the many different contributions that each of you bring from the very different areas in which your own expertise touches and your own organizational experiences bring to the table. Because as you know from our orientation and from previous discussions, the mission of AHRQ is almost unbelievable. And that is to improve the healthcare of the United States in all its dimensions. And we're a tiny organization, and that's a mighty mission. But I think we're all up to it. So, so one of the things I wanted to do was to let you know that since our last meeting, I had a chance to present to do what I promised to do, which was to make sure that the mission of AHRQ was better understood by our department leadership and by those who needed to understand the role and mission of AHRQ in this period of crisis in American healthcare. And that period of crisis is an opportunity for us to actually do our job and to meet our mission, to actually improve healthcare in the United States. And as a non-regulatory agency, we have to do it with carrots, not with sticks. And so trying to figure out what those carrots ought to be, how they ought to be shaped, the tools that we need to use, that's really what I need your help understanding how to do and how to get us there. And so part of what I wanted to share with you, though, was the fact that one of the ways we do our work has largely been through both an intramural research program, but also an extensive extramural research program. And many times we don't recognize the significant research that's going on that's making that mission possible. So I wanted to do today is share a few highlights of what that extramural research looks like. So let me just draw your attention to the second piece. The first piece we'll talk about to some degree in the next section, which is racial inequality and prescription opioid receipt. But what was really important was this November article, which was about low value care at an actionable level of individual health services as a way of really changing which kinds of health systems provide low value care and which don't. So it provides us an opportunity to look at the structure of primary care and how that affects what's going on in our healthcare system. Another significant piece was, I think, it really changed the story around COVID. COVID-19 and the racial and ethnic disparities in health risk, employment, and household composition. This article, which was published in July of 2020, really shifted away from the way we thought about how racial and ethnic minorities were experiencing the COVID epidemic. And move from a focus of only pre-existing conditions to really a focus on the job characteristics and the living circumstances that people were experiencing. As many of you recall, many, like in my community, were part of what was called essential workers. And yet many of those people were being exposed on an ongoing basis, but weren't part of the headlines. They in fact died at a greater level. They were hospitalized at a greater rate, but that wasn't part of the story early on. And the notion had been it was mostly in nursing homes and older people who were dying. But this particular piece changed that discussion. And for many of you who may not know, a large number of children over 200,000 children were left orphaned as a result of COVID-19 in the first wave or two. And most of those children are from the Southwest in low-income working family communities. Well, the one area that we have been trying to work on is really the issue of how do you make healthcare more equitable? And how do we produce the scientific evidence that healthcare systems need to make healthcare more equitable? What does that really mean for healthcare delivery systems? So we're increasingly trying to look at what that means for us in the kinds of carrots, as I suggested, or tools that we can make available to the healthcare system to make care more equitable. Part of the president's priorities and the departmental priorities were really about not only transforming the healthcare system, which is what I said we're trying to do, and we're trying to make recognize, excuse me, make more recognizable as our mission. But the second issue is really how do we dismantle the structural racism in our healthcare system to achieve equity? That's a harder question to answer. And I think many healthcare organizations are trying to address this now. I know that the American Hospital Association has started a new initiative focused on equity and achieving equity. But what is it we as a federal government agency can do to complement what our private sector organizations are doing? So I'm going to ask the NAC to please create a subcommittee that would help us make recommendations to the National Advisory Committee about opportunities for AHRQ to improve equity in healthcare. We need to be, next week, we will be holding a health equity summit as a way of trying to at least begin to jumpstart those discussions about how we in fact provide that kind of support to our healthcare systems across the country. But we need to be ready potentially to figure out how we take the next steps. And we can only take those next steps with your assistance and guidance. Edmundo?
Thank you. Thanks for your report. A couple points to follow up on based on that report. One, if you have questions, including if you're in the room, please use the raise hand function on Zoom, and that way we can actually track everyone and make sure that we get your questions or comments appropriately addressed. Second, so the idea of a SNAC or a subcommittee of the National Advisory Council is a useful tool for the NAC to use, especially when it comes to really digging in on a particular topic. In this case, it's health equity. And what it allows AHRQ to do is leverage the NAC overall, but do it more efficiently and effectively and really engage. And what happens with the SNAC is it actually reports back up to this body. And then we acknowledge those thoughts, those recommendations, those ideas that have come out of that SNAC. And it becomes a part of our advisory role in the NAC. But it does, again, allow again a deeper dive into critical topics like health equity. You guys should have received and reviewed the report out from the SNAC on quality measurement, right? And so very similarly, and we have an ongoing SNAC on patient-centered outcomes research as well. So what we will take a vote on it. For those, the way that the SNAC works is that that AHRQ picks the members of the SNAC. But if you are interested in jumping in on this one, shoot Jamie a note, and we'll review the membership of the SNAC. So before we take a formal vote on the creation of a SNAC to focus on health equity, Just want to make sure there's any question. I don't see anything. I don't think I see any hands raised. I can't see the whole screen. Yeah, I don't see any hands raised. So, and I see Youngling's hand, but yeah, I actually see your physical hand as opposed to the Zoom hand, but Youngling, go anyway. Just Youngling, you.
I saw, I'm sorry, I thought you were asking if you want to join the equity subcommittee or anything.
Oh, I see. Yeah, so if you do want to join that subcommittee, then send Jamie a note by email.
Oh, okay.
Yeah.
I'm sorry, I misunderstood.
No worries. No worries. Go ahead, Ken. Come off. I see. Raise your hand on the Zoom so we can collect both virtual and in-person requests to speak. On the I'm sorry, when I say raise your hand on the Zoom, there's literally a function at the bottom of your Zoom screen that says raise hand. That's what I mean by raise your hand on the Zoom. Sorry, I should be more clear. I stop being the digital guy for a minute and actually explain things in ways that people can understand. There we go. We're collecting some comments or some questions. Let's give me one sec. All right, who did I see? Kanan, you're first up.
Yeah, thank you. Just a quick question on, do we need to have any mandates and goals for the SNAC and the time frame in which the report needs to be put forth back to NAC?
That's a great question. How do we typically manage that?
In the past, we have had, we generally approve a SNAC to be approved for up to 1 year. And then what happens is the SNAC reports back at NAC meetings, and if the group determines that more work is needed, then you can vote to continue the SNAC in subsequent years, but usually 12 months at a time.
Next up, come on.
Thank you. You know, I'm so appreciative and thankful that, you know, to spotlight equity, and I'm thankful to Dr. Valdez and the rest of the team. One clarification I do have, since equity is really cross-cutting across really everything that we do, the development of a SNAC, does that allow for sort of the cross-cutting across all of AHRQ's different programs and centers?
You can jump in on that. Yep.
The development of the SNAC allows us to do something we normally cannot do, which is engage a group of individuals in a set of discussions around a particular topic more than once. And so in order to create an opportunity for people to have an ongoing set of dialogues over a period of time, we need some kind of mechanism like the SNAC in order to conduct that business that includes people from outside of the agency.
Perfect. Thank you for that clarification.
Any other questions before we call the vote? All right, seeing none, we're going to, the vote is to create, again, a subcommittee of the National Advisory Council focused on health equity. Wait, hold, I've got a, no, I don't. So that's the vote. Anyone want to move that? Make a motion?
Motion. Oh, sorry.
Hold on, let's move in second, then we'll go to questions. Any seconds? Second, come on. All right.
Second.
It's been moved and seconded. Thank you. Now we'll go to question before we finalize the vote. Youngling, you had a question?
No, I was trying to move the motion.
Okay, gotcha. All right, so the motion's been moved and seconded. All those in favor, say aye.
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 Thank you.
Aye.
Any opposed? Raise your hand in the Zoom if you're remote, if you're opposed. Got it. So that motion carries. We will establish a snack on health equity, and to be reporting back to the NAC at the appropriate times. I think the next order of business is going to be, I think it's back to you, Dr. Rodriguez. Is that right? Yes, it is. It's back to you. So we're gonna talk about the the quality in different healthcare settings.
Right. Earlier today, the NAC was broken up into subgroups to discuss what quality of care really means in 4 different areas: nursing home, rehab care, home health care, hospice, and behavioral health. The NAC groups were asked to answer or discuss 3 questions. What does it mean to deliver quality care in these particular environments? What does it mean to receive quality care in these environments? And what will the quality of care in these environments mean in the future? Or what should it mean in the future to receive high quality care in these settings? I believe at this point, we're going to have each of the NAC subgroups report out, and I turn it back over to you.
Sounds good. Let's do that. So let's go in order. The assumption being that in each of your groups, you did assign someone to capture notes and to report out. I'm making that assumption. So we will start with the order this mentioned. So we'll start with the nursing home group. And do we have a? There we go. Awesome. All right. So let's go with the nursing home report out. You've got 5 minutes for your report out.
Thank you, Edmondo. And we really had a very robust discussion in our group, and I invite the rest of my colleagues to chime in if I missed anything. We, in the sort of thinking about, so the question of healthcare quality, what does it look like now and in the future, specifically related to nursing homes? We recognize that it takes the trifecta of patient, family caregiver, and healthcare staff to really answer that question. We also acknowledge that while some of us have a deep personal or professional familiarity with nursing homes, we have limitations in speaking about the patient perspective. We also recognize that the goals might be different for those that are engaging with nursing homes for a short stay versus a longer term stay, and in different populations, things like end of life, long term, or those with cognitive disability. Are some of our general comments, are that quality for a nursing home definitely might be different when compared to sort of other types of healthcare settings. And we also acknowledge that there is a tremendous gap in access, whether it be proximity or other structural barriers to access. We believe that transparency regarding the transformation process and measurement strategy is crucial to moving to the next era of high quality care for nursing homes, and really the concept of long-term care as a whole. Some specific comments related to structure, process, and outcome. When it relates to structure, we believe that a high quality long-term care environment is a trustworthy home-like setting that promotes healing and provides patients with dignity and choice. We really discussed sort of Maslow's hierarchy of needs here. We also recognize that an equity-based technology infrastructure that can be easily accessed by both staff and patients is crucial to really sort of being able to solve problems such as accessibility and safety. One thing that was noted was, are there PFACs, patient family advisory councils for nursing homes, and who's part of that composition? We also really wanted to emphasize that should we think about sort of addressing long-term needs, recognizing that there are really multiple ways of doing this, and that there will be needed to be changes to the payment models that will sort of allow that to happen. When it comes to process, we really emphasize that coordination of care is important, recognizing that residents will often connect to multiple types of healthcare, and how do we connect all of that care that occurs in different environments. We also recognize that processes that give patients choice is crucial, as well as processes that allow healthcare staff to give true input into future design of structure and processes. We had a lot of discussion around outcomes, and again, highlighting that there are differences perhaps in different types of residents, and what you may focus on for measurement might be different. We also recognize that families and caregivers are an important part of the care team, and what matters to folks is crucial to take into consideration. We recognize that current methods of measurement may not be hitting the mark, and that outcomes that are meaningful to people can be different and may not be measured by our current sort of tools that are available. We also recognize that there's an important need to understand the barriers to sort of keeping people in their homes when it is their preference to do so. And there is currently a paucity of mental health services related and well-being related measures. So what does the future look like? Potentially very exciting. We really need to think differently about long-term care rather than sort of nursing home care, with models that can support various elements of that long-term care. Sort of thinking about this as long-term care will catalyze conversations around accessibility and equity. We also recognize the really crucial need to co-design measures that get to the heart of what outcomes matter to people and families who are engaging in long-term care. We discussed prioritizing a limited set of measures to ensure that innovation is not stifled as people are sort of looking at all of the sort of processes and outcomes for long-term care. And we also recognize that the future of quality long-term care or nursing home care is a well-trained, responsive, robust workforce that is engaged in designing the future of long-term care. Thank you.
That was a very good report out. Thank you very much. Actually, what I'd like to do is take a couple of questions on that. I'll just use a couple more minutes. So if anyone has a question on that, please go ahead and raise your hand on the Zoom. Asaf's already jumped on, so go ahead.
Well, I think that was, what a robust conversation for, 57 minutes or an hour that we had and that you had, and I appreciate the incredible summary. One thing that the summary, that your point about workforce at the end made me think about as an opportunity for specifically AHRQ to think and perhaps even fund research around is what COVID in its horrendous, catastrophic march through the long-term care system across the country. In Massachusetts, for instance, 14% of nursing home residents died of COVID, not were affected by COVID, died of COVID in the first year. When we think about an improvement mechanism for it, one of the things that quickly became apparent when we think about workforce is that there are at least 4 layers. And the 4 layers are not amenable to quality improvement strategies that work in other parts of the healthcare system. So there's the layer of employed staff at a nursing home or long-term care facility, and they have tenuous but existing operational and quality improvement chains. And then there's a second layer that became quite apparent, is that there's a layer of temporary or term positions. These are staff members that come and go. They don't have very good connections to management, to supportive supervision, to existing quality improvement routes, if they're even exposed to it at all, because they're thought of as temporary and on the side and not part of the core workforce. And then there's a third layer in some long-term care facilities, which is private duty or families hiring staff that come into the environment. In fact, that was a big problem at the beginning of COVID, is like literally spread mechanisms. And then there's the fourth layer that always gets forgotten, which is, of course, families and caregivers providing the caregiving to their family members within nursing home facilities. So, and they're often unpaid, unacknowledged, not included in quality improvement, not measured, et cetera, and completely ignored. So these 4 layers of critical workforce barely talk to each other, are rarely understood, and the ways in which we use quality improvement implementation methods to improve processes, actions, training, I feel like is a huge opportunity for AHRQ to do some good implementation focused research on. Over.
Thank you. A great kind of frame, a kind of conceptual frame around this work. Got about a minute left in this conversation. I see two more hands up, so we'll get to those two before we go to the next conversation. So Youngling, I saw you first.
Thank you, Armando. I think I don't know if maybe I didn't hear in the summary. It's excellent. I just thought that there's one thing we observed in our state and heard a conversation is a shortage of staff at nursing home. And lots of time they do not have enough trained people, staff at nursing home, especially during the COVID era. And I felt that has really serious impact on the quality of care that can be provided, in the nursing care, long-term care settings. I don't know this is that AHRQ would be able to address this or in collaboration with others. I don't know, but I think this is a serious problem that we're facing right now. Thank you.
Thank you. Patrick.
Right.
You might want to bring your mic closer just so everyone can hear it.
Here. Unmute myself. Okay. Can you hear me now?
Bring it closer. Bring it a little bit closer.
Okay. Right. So I just actually wanted to reinforce what Yanling said, the same issue on my mind as well, which is the tremendous workforce issues that we have in the long-term care setting. And the fact that that the vast majority of long-term care residential facilities are understaffed and have had difficulty retaining their staff. There aren't mechanisms in place to ensure long-term retention of staff. And in many cases, the staff that are there feel like they don't have the backup that they need from their employers to continue doing the work that they need to do. So anyway, this is just an area that is so critical. And we need to understand how to improve the workforce in long-term care and how to ensure that there are incentive mechanisms in place, that there are payment mechanisms in place that support the improvements that we need to see in the workforce.
Agreed. Thank you. Let's move to the next topic, which is home health care. Who's got home health care?
I do, thanks. My group had a very rich discussion, and in fact, there were so many overlaps with the excellent presentation that you just heard about skilled nursing facilities that I think we'll all benefit from thinking about how these types of care have more similar challenges in the areas of quality and being future looking than differences. So at the risk of repeating some of them, I will tell you fully about what my group discussed. When we started in to discuss question one, which is what does it mean to deliver quality care in the home health setting, we said, really, you can just go back to the quadruple aim. You can think about care being, provided at the right time, care enhancing the patient experience, clear and efficient communication, and also bias reduction and attention to anti-racism, as was mentioned by the first group. We also had a similar discussion about using the right performance metrics. One of our members noted that new performance metrics or quality metrics will be unveiled this January, and that may be proving challenging to home health agencies. Of course, you want quality metrics to deliver high quality care, and by definition, delivering high quality care as close to the home as possible is a goal, and home health care helps to support that. It also wants to, in accordance with that overall goal, make sure that it is used to reduce readmissions and unplanned ED visits. So one of our members also noted, and this wasn't mentioned before, that an opportunity to participate in clinical research, especially clinical trials within the home health setting, was important and something that was often overlooked. There was a discussion of things that are unique to the home setting, including safety issues. both for home health workers and for patients. When you have someone in the home, you have an increased need for trust and safety, again, on both sides of the equation. And especially given that some of these patients are by definition homebound and many experience cognitive deficits and difficulties, you need to worry about the safety of their person and property as well, unfortunately. There's also the dimension of safety in terms of infection control, which was mentioned earlier when you have people seeing multiple patients at that level, as Asaf said, of the workforce. We did, sorry, to loop back, this is a little out of order, but we talked similarly about using the minimum number of quality metrics to get actionable data. We thought that a direction for that, again, which is similar to what was going on in the skilled nursing area, is that these metrics should be more personalized. There's a wide variety of patients receiving care in their home, formal care in their home, and quality metrics should reflect that. We'll also note forward-looking that we need better technology to facilitate tailoring of quality metrics for patients and to make the information collected during visits more accessible to the entire care team. In addition, if there's more data collected, there needs to be better organization and better technology to make that data, those data usable. And finally, we had a discussion of how high quality care delivery required well providers as well as patients or people receiving care. And that included everyone operating at the top of their license and being a full member of the care team. When we moved to question 2, we actually had a robust discussion about why delivery and receipt quality should be separate. Because of course they should follow from each other if quality is high, the level of quality is high technically, and communication with the patient, their family, and all caregivers is strong. And that led to a discussion about quality in the receipt of care in the home setting being really fundamentally around good communication, because this care must be tailored to what matters most to the patient. It also needs to be culturally appropriate and address the needs of the family and the informal and any other informal caregivers. The goal for this care should be that people feel cared for, and that is the highest and best measure of quality. Again, we talked about need for safety in terms of infection, personnel and property, and the need to develop trust. We also had a robust discussion about the need to involve family members and informal caregivers and training to deliver care to people in their homes. There needs to be time made available so that caregivers can be trained and show that they can do what needs to be done to keep people safely in their homes. And there was a discussion of appropriate use of telehealth, that it might be possible for home health agency staff and the like to facilitate use of telehealth, that would allow other members of the care team to see the home environment, which can be important for clinical decision-making, incorporate through technology family members, support continuity of care, and increase transparency of information sharing. In doing so, use of home health workers might make telehealth less likely to perpetuate existing disparities, which can include disparities in access to technology. And then finally, we noted that in order to create the highest quality experience for the person receiving home health care, it would be great if the formal home health care workforce could coordinate to make sure that the home environment was safe in terms of things like adequate air conditioning, hygiene, meal provision, and the like. Finally, when we turned to looking at the future, as a group, I thought we're very optimistic that technology will really enhance our ability to deliver high quality care in the home setting that meets the goal of patients. We talked about the variety of types of data that might be collected to support more efficient and high quality care, including patient collected information, for example, around weight or pulse ox through mobile and remotely and wired devices. But we also need a concurrent, sort of build, if you will, IT build, to manage the volume of information that might be available and to make sure that it supports and enables better quality communication between clinicians and patients and among clinicians in the entire care team. So we had a rich discussion about the idea of being able to convey images, graphics, trends, and we had an interesting suggestion about the use of video, in particular animated video that might help patients to understand what's going on better and be easier to make culturally appropriate, translate into multiple languages and the like. Finally, we talked about how we need to have a systems thinking approach to home health. There are so many new modes and models of care, including hospital at home, which involves care in the home dialysis and the like. And we should be thinking about this not just in the context of individual well-being, but in the context of community and care team well-being. This could, as was mentioned earlier in the SNF discussion, include rethinking and the alignment of payments with what patients truly value. And then finally, we ended up back at the quadruple aim. How do we make sure in any future scenario that patient goals, workforce goals, and caregiver goals are all incorporated into what we conceive of as quality home health care? Thank you, and I'm sorry that report out was so lengthy.
Thank you. That any other, we have about 2 minutes maybe for any questions, comments, additions for that one. Maya, go for it.
Hi, thank you, Melinda. And I agree with you. It's stunning how much overlap there was. I especially appreciate the point about culturally appropriate care, which of course we ideally want in all settings, but when it's in someone's home, it's particularly critical. And I'll just share that, for not all, because no group is homogeneous, but for many Asian families, the notion of having a stranger come into your home to provide intimate services, that's a real cultural bridge to cross. So I really appreciate your calling that out.
Thank you. Susan, go for it.
Yeah, I just want to add, and I think this is also relevant for the nursing home discussion. We did talk briefly about how it might be quite helpful to have something like the survey of patient safety culture that we now have for hospitals and ambulatory settings, for home health care organizations. And I think we're also already working on that for nursing home, but those could also give us very valuable information that people could use for improvement and hopefully retention of staff.
Oh, yeah, great idea. Let's move to the next topic, which is hospice. Andy.
How about this? Excellent. So I will try to make non-overlapping comments. If I miss anything, please remember the team, call them out for me. So hospice is a lot like the things we've talked about, except it's all of them at the same time. It's inpatient, it's outpatient, it's home, and sometimes virtual. So we thought all of those settings were relevant and faced many of the same challenges that we've talked about so far. The contrasts, I think, as people approach the end of their life, are that it's really marked by what someone called burdensome transitions, the kind of friction from moving from one phase of care to another, and also the communication just from moving one set of providers to another. Even when the field of palliative medicine and hospice, the payment structure set up pose a very large barrier to making a smooth transition to a symptom-focused management to a kind of a goals of care focused management. We spent a lot of, we focused a lot on the individual outcomes at the end, saying that it ends up being a very individual journey as well. So some of the measures that could potentially be indicated in the delivery of hospice care were a little hard to imagine without really thinking carefully about why a patient might choose to get chemotherapy up until the last week of their life, as opposed to choosing hospice a lot earlier. Regardless, though, we really focused a lot on service availability as a potential quality measure, because we felt like there were real gaps in the type and the quality of hospice services in a community. There was a lot of focus and discussion on how to capture the patient perspective, even though we worry a lot about low response rates from the surveys that are sent out. They felt there was still very informative information. concordant with other groups, staff satisfaction, workforce satisfaction. It's very difficult work. And for all the reasons it's difficult to do home care and nursing home care, hospice care just seems to add a little bit more difficulty in the current era. Measuring satisfaction and turnover in the hospice workforce, again, all these the kind of different settings seemed important. We thought the measures should, like in all aspects of measurement, the measures is harder for us to imagine measures that were actionable right now, but thinking through the structures might be a way to start a measurement and quality improvement journey in hospice medicine across all phases of care, particularly as we start to develop more technologies that can measure patient encounters and measure patient engagement with the system, family engagement with the system. We don't want a proliferation of measures, but just wanted to think about structures and processes that could be focused on initially to kind of compel a longitudinal view of a patient's end-of-life care. I think I'll stop there and let the rest of my team add any color if there's anything to add. Otherwise, I'll answer questions.
Yeah. Any raise your hand for folks who want to jump in and add anything that we think is incremental to the conversation here. Go for it, Gina.
Yeah, just.
Turn the mute off.
Thank you. Sorry about that. I just wanted to add that, finding a way to integrate palliative care and hospice care, I think is another opportunity. There is some regulations in terms of, regulatory barriers with the 6 months or less prognosis for hospice, but having that integrated care, having the integration between palliative care and hospice, I think is, just one way in bringing it all together, and one way to look at it.
Yeah, thank you. Kathy?
Something I didn't hear mentioned that is important in the hospice related discussion is the need to really increase the perception of the value of both palliative care and hospice among the broadly the healthcare team. I think it can contribute to delayed referrals and really calls for the need to do some work around the perception of both those services among the healthcare team.
Yeah, that's a good point. I don't think that we discussed in our group. Susan?
Yeah, I just want to underscore what Kathy just said, because we struggle with that constantly. I also do work around engagement of clinician staff and patients with palliative care at Mass General. And it's a huge issue for our staff. It's also a huge issue for our patients, to the point that we have had ongoing, and I'm sure all palliative care people do, about do we just need to not call this palliative care because it has such a negative connotation with so many people, and doesn't really signal how incredibly helpful and important it is and can be.
Yeah. Good point. We actually call it our supportive care service in our institution.
Yeah.
Maria?
Yeah, we kind of discussed that, but in the context of health systems and hospitals not being measured and held accountable for these services. So that was kind of the way in which we addressed an excellent point that you are both bringing up.
Very good. Let's go to our last topic here, which is behavioral health. Who's got that report out?
So our note taker seems to have disappeared. So I'm going to do my best to reconstruct, at the risk of my own anxiety, behavioral health, and just ask the other group members to feel free to jump in. We started our conversation talking about behavioral health is so broad, and we're talking about about mental health and substance abuse and the whole range of different venues of care could we really generalize? And I think we were all comfortable saying in the end, yes, there are a lot of common attributes that would work across the full spectrum, and sort of the same kinds of process and outcome measures that apply in many other sectors. I think a few of the key themes that kept coming up were the whole idea of integration, both integration between physical health and mental health, and really focusing on primary care and its integration and familiarity with and referral to at appropriate points in time, the behavioral health system. We also talked about integration between health plans and PBMs, and how the way we've structured the payment and financing system oftentimes is creating barriers to effective coordination of services. One of the key outcomes that we talked about is the patient experience with care, and how important it is to measure that, to really think about what are the metrics for patient engagement, satisfaction, and what are the challenges in measuring in the behavioral health population. Just speaking of patient experience, one of the key things we talked about is, from the patient's perspective, one of the key metrics is access to care. And we talked about how one of the biggest problems is people who have behavioral health needs can't access care in a timely fashion. We started then to talk about outcomes and the range of outcomes that would be reasonable to measure. We looked at some of the challenges with looking at things like readmissions or recidivism. I'm muted here. Yeah, I'm muted. Do you want to check it? Yeah, okay, I'll just keep talking. One of the key issues, and we were thinking about where does AHRQ fit in here, is how do you risk adjust for outcomes metrics when you're talking about behavioral health? And particularly when we start to get into creating public reporting or some sort of accountability or value-based payment, how critical it will be to risk adjust whatever outcomes we're measuring. And I don't think we have very good methods currently for doing that. Related to the conversation about value, I'll say that there was a lot of discussion about how the behavioral health system is, as Caroline put it, fraught with fraud, abuse, and waste. And how are we going to measure those? What can we do to actually control that? And it relates closely to quality, because so much of that fraud or abuse is at the disadvantage of the patient. The question about sort of quality from the system view or from our view versus the patient's view, we felt that those are really two sides of the same question, that we can't separate that. And that when we're talking about quality in behavioral health, we're really talking about an integrated kind of view with both the patient and provider and system perspectives all sort of blended together. Hope that does justice, group. Any additional thoughts?
Anyone want to raise your hand and jump in on to add some thoughts? Pretty thorough for a last minute subject here. Yanling, I saw your hand first.
Okay, Neil, you did a great job for putting a summary. I think, we emphasize a lot about, the integrated care and team care, in a sense that, and treating patient as a whole person rather than have a mental problem or have a, medical condition, and getting patient family involved. And also the mental, the behavioral health treatment should be evidence-based. Sometimes when we say, you just dispense the medication, you screen patient, and then you found, oh, you need a treatment, and then you give medication. But there's not much coordinated care, not much follow-up. We want to really have evidence care, and then know what at the receiving end, the patient end, what is outcome, whether their functionality, their function well, they have been improved, they have any supporting system and whether they can get adequate access to their care. In terms of the measurements, we think, I think we talk about the outcome measure, sometimes maybe like a composite measure based on, how focused on the improvement at the patient end, and using patient incorporated with the patient reported outcome and as a quality measure for this area.
Yeah, great thoughts, Shannon. Mike, so you.
Yes, thank you very much. Could you expand more on what you mean by fraud, waste, and abuse?
Yeah.
Yeah, well, Caroline, who had to step out of the room, is really the one who brought that up, but I think there was agreement on that. So one of the points she made was that whenever a new service is available, like some payer decides to pay for a service, particularly CMS, immediately there's a whole groundswell of providers springing up out of the earth and billing for that procedure. And so there's a lot of, I think, suspect care that may not actually be delivered, but is billed.
Thank you. Patrick, go for it.
Yeah, two other just connections. It was Caroline was doing a brilliant job taking notes, but one of the points that I think came up was, the importance of kind of moving to a next generation of outcome measures for behavioral health. So the first generation of outcome measures has really focused, process measures about prescribing practices, and then outcome measures around readmission to inpatient facilities, and in some cases, remission of depression symptoms. But the next generation would focus more on quality of life and role functioning, the sort of longer term outcomes that perhaps matter more to our patients and their families. And also the importance of linking this with chronic pain management, understanding how depression in particular has such a profound impact on the utilization of services for medical conditions. And many patients end up on opioid medications. Many patients, of course, have now converted to non-prescription opioids. And so we have this tremendous problem of the opioid epidemic that has been refractory to everything that we've tried to do in the policy space for the last 6 years or so. So obviously, we need increasing attention and coordination of effort between AHRQ, SAMHSA, NIH, other agencies that are active in this space to better understand how to provide coordinated integrated services.
Thank you, Patrick. So great report outs, very robust discussions were happening in all four groups. I thought it was just our group, but apparently it was the other groups too. No, this is really good and really good conversation. Here's what I'd like to do is let's take a couple minutes here and think about themes that you heard that were common across the presentations. Take a minute, maybe even jot it down. You should have some notes in front of you, right? What themes are we hearing that we think were pretty common? But I also actually want you to think about if you heard some things that are unique. If you heard some things that are unique in any of these settings, try to capture some of that as well. I think that could also be useful. So common themes and some setting uniqueness that may want to be called out. And you are certainly free to raise your hand and comment. If you don't, I will call on you. So you might as well go ahead and raise your hand anyway. Oh, great. 2 people that I was going to call on just raised their hand. Perfect. So let's start with Sherry.
Terrific. So in part answering your most recent question, I'm going to go with recency first, which is about the overlap of things. It is remarkable that that the theme of person-centeredness, what matters to people, who the services are provided to, really runs through, which is, that's a really important moral high ground here. For otherwise, what are we doing? I think there is also, what's interesting is, Andrew, your comment, I'm going to try to be specific to hospice. And yet, we know that there are beneficiaries, patients who it runs across all, right? So I think some continuity or intentional continuity, perhaps, so that it will capture what quality looks like as people traverse the healthcare system. That's also a theme that I heard, and also including families, not just the person. I will also say, just FYI, that Patrick's comments about about behavioral health, these are exactly the issues that we wrestled with in constructing the CMS behavioral health strategy, trying to put the different elements and conditions onto the same side of the coin, because Medicare beneficiaries have it all. And mental health, substance abuse, pain. So how to actually focus again on the person who's being served, not just one condition. So anyway, those are some reflections, and these are also themes that are reflected in the CMS quality strategy. So great alignment there. Thank you.
Awesome. Thank you. That's great to hear. Henry, you're up next.
Yeah, thank you so much, Edmondo. I was struck actually listening to the presentations, how these four settings have a huge number of similarities. But I would first draw the distinction between procedures and surgical quality, right? Where much more mature, many more measures. And we're used to looking at technical competence like door to balloon, complications, safety, and much more robust. And higher reimbursement. When I looked at this, what struck me was low reimbursement, typically compared to the surgery and procedural practice. Much more importance of what you said, patient-centeredness or patient values, preferences, and goals, and making sure we understand those. Much more emphasis on communication, transitions of care, and the value of coaches. I actually thought these four different contexts actually were more similar than different. And if we're developing measures, it would be great to harmonize as much as we can across nursing homes, home health, hospice, skilled nursing facilities, rehab, all these care settings where it's not acute care, not diagnostic or therapeutic typically, and more about promotion of health, wellness, and well-being, and more of a chronic setting, although hospice is not, hopefully not chronic, but it could be. So those are my comments.
No, great thoughts. And so as I call on the next group of folks, there's a lot of hands raised, and I see them all. One thing I'll challenge you with, so following up on that thought is, if we are going to harmonize some of these, because I agree, there's a lot of common themes there. Where might that fall down or fall apart, because there's enough difference between the settings that we really should call that difference out. So just kind of keep that in mind as we call on the next couple of folks. And Susan, you're up next.
Thank you. So I have three common themes that I'm hearing. The importance of patient and family partnerships in the co-design of care and in quality improvement activities, so that we help get it right and we can actually personalize care in a way that really matters to people. I think workforce safety and engagement is absolutely critical right now. I don't need to emphasize that. And then I think we have to really think about it. And I think the snack on quality measurement also spent a lot of time on this, is how we really continue what I think of as measurement hygiene. How are we sunsetting measures that no longer are helpful and don't provide us with information that we can use, many of which are often very expensive to collect and monitor? And how do we focus on measures that are very actionable and that hopefully are meaningful both to clinicians, administrators, and patients and families?
Yeah, great. I love the measurement hygiene concept too. And I think it was a common theme across the groups. Neil, you're up.
So I'm embarrassed to think that we in our behavioral health group didn't talk at all about equity or disparities. And I don't recall if any of the other groups mentioned that in their report out. So just an observation, critical. And this is why that snack we voted on earlier is so important, because it's hard to imagine a 1-hour conversation about behavioral health and never talking about disparities, where it's a tremendous issue.
No, great call out. We did talk about culturally appropriate care. We did mention, but I don't know that we specifically called out disparities. And I think to your point, it is a common theme in all the settings. And so I think that's certainly something that should be captured. So we did. So Melinda said we did. Thank you. But I still think it's a common theme. So everyone should have mentioned it. So thanks. That's a great call out. Kamal, you're next.
Thank you. The themes that stood out to me are just sort of the need for revised payment structures that really promote health and care and equity. That was sort of the lens that we sort of talked about when it relates to improving accessibility to care. And then another theme, which has not been mentioned again, is sort of this idea of the connectedness, the transitions, the coordination, crucial to sort of all of the work that we do across all of these 4 healthcare settings.
Agreed. Andy.
I would just raise up workforce one more time as maybe a separate line. It didn't feel like it's a measurement part of any of these, but it's such an important cofactor to all of these projects that it feels like a separate line of inquiry. It has impact on health equity, it has impact on value, maldistribution, poor training, inaccessible. It feels like a different line of research. But it was certainly woven into all of the things we talked about here today. And I'm looking at Dr. Valdez as I'm saying this, but it feels like a separate line of inquiry at the agency that I haven't seen emphasized that much yet. It's other places, but not here as much as I think it could be.
Yeah, thank you, Andy, and I agreed. I think that is certainly a focus and things that we have talked about in this setting. And I want to pull back. I want to pull in Asaf's comments on the chat because they actually are consistent with earlier comments around the impact of kind of a fee-for-service dominated system and how that makes that payment reform concept challenging. And so I think that is a common theme, and we certainly talked about it pretty much certainly in most of the groups that we had here. Maya, you're up next.
I won't talk about payment today. I would like a break from talking about payment. I will talk about payment at next week's meeting. But 2 other comments. One is just with respect to metric hygiene. And we raised this point in our group, but I want to just, I think a cross-cutting theme here is looking for opportunities to move away from the clinical guideline-based set of measurement framings and think more about goal attainment and how we can modernize measurement of goal attainment, something NCQA and others are working on, because that provides for a lot of flexibility in terms of the patient populations you're serving, the care setting you happen to be in. So just putting that out there. But really what I wanted to bring up is, a lot of the groups and several commenters have talked about care coordination, which I used to always think of the kind of way that I thought about hip exams in medical school, like, it's there, but where is it actually? And so lately have been investing a lot more in dissecting the anatomy of care coordination. And, based on published frameworks and our own discussions with stakeholders, we've identified 13 distinct functions in care coordination. And so I think it becomes obvious that no one entity can be accountable for all 13 functions. And we need to wrestle with this question of what are the units of accountability for which functions, and also be really clear that the goal is to take the burden of coordination off of patients and families, but the goal is not to remove the decision-making from them. And so, you know, what I think that plays out in all of the downstream issues about who owns the data that's used for care coordination. How does one share a story about who this person is from care setting to care setting? Anyway, I know it's an adjacent issue, but we've all named it. I just want to dissect the hip.
Good, great point. I love the analogy. Who's Jaji? I think you're up next.
In order to support the harmonization of the conceptual themes for measurement across different areas, and we need the harmonization of data, especially for future measurement. And without a standardized data set and the formatted convergence, all of this, nothing's going to happen. And then next question is, who is going to collect the data, which is always a problem. And even if you collect that in one place, in order to do comparison, evaluation, and measurement, you have to have the data sets shared, communicated in a way that is meaningful.
Great points. See, Melinda.
Hi, thank you. So I do think there are a lot of common themes, which I will not repeat. I've put some of them in the chat, and I think we can all agree on them and agree that there are more common themes than differences amongst these four areas. But I do want us to not forget that we need to be improving and building for the future. And so I think the future is more home-based care. And it's not just going to be custodial or low tech. It will be diagnostic. It will be therapeutic. We will do more telehealth, for example. And so we should keep that in mind, because otherwise we'll be perfecting a system which will not meet our future needs.
Great points. And I can certainly second the tech-enabled services component of our future care delivery models. Mireille?
Yeah, I mean, I just wanted to point out that two of these are kind of settings of care, home health and SNF, and two of these are kind of types of care. And we've talked about them as distinct because of our payment system and our benefit design. And that, you know, part of moving this to the future maybe is moving away from that structure. And then we, you know, have a different way of thinking about transitions of care when it's not moving in and out of different kind of benefit design. So just wanted to point that out.
Great call out. Yanling, you're up.
Yeah, thank you, Monica. In terms of you know, the equity in the care in all settings, I just want to draw your attention that CDC just published a report in their study about the overuse of the opioid use dramatically increased in 2020 for you know, in the minority population. The death rate for Black population increased about 40%, and Native American and American Indians, they increased about 30%. Besides the you know, the pandemic, that's a problem for everybody, but they particularly have a problem for access care. And that is so important in all settings that, you know, we gotta bring this particular populations into the conversation to resolve the access care issue before we can even talk about the quality of care and safety.
Yeah, good call. Kanan.
Just a couple of comments. One is just emphasizing the point that the second group brought up related to clinical trials and research. It's possible that the other groups talked about it, but the importance of needing to do these clinical trials and research, with the emphasis that these trials are shorter in duration, with methodologies that are different than what's been done in the past so that we can get the data that we need in a more efficient way to dictate some of these process and outcome measures moving forward. The second is technology, and I think that's been alluded to a little bit too, in terms of not only helping us be more effective and efficient in delivering care, but also using it as a way to collect data, analyze it, and then make modifications if needed to the measures that are being developed in a fast and effective way moving forward.
Great, really robust discussion. Thanks for everyone for leaning in and commenting. I didn't even have to call out anyone or call on anyone. That's awesome, making my job easy. Really good. So great themes. Maybe not as much in terms of what's distinct between the four groups. One thing to think about is, so now what? So what do we do? What do we do next? One thing we can do, at least, is to call some attention to some of the topics that we've discussed. Is one of the tools that the NAC has is the opportunity to create a blog post on AHRQ's website, so we can coordinate that through the AHRQ staff. So if that is of interest, this topic, the reason why I'm calling this out is this discussion was so robust. I feel like we should capture it and share it. I just thought it was really robust. So and is this something we can do on the side, and we could probably, I think, Jamie, if we coordinate it, can we coordinate it through you? Yeah. So what we'll do is, you guys, if anyone wants to jump in and help write up a blog post on this that we can put on the AHRQ website, just shoot Jamie a note. I'm excited. I think we should, even though we don't have all the answers, I think we should just at least start to capture and communicate this robust discussion. So that'll be a homework assignment only for those who are interested, moving out of the meeting. But other than that, any other comments on what we should do about what we've captured? Or actually, let me hold that. So Dr. Valdez, you've obviously been listening to this, again, very robust discussion, right? And you spurred it. You called it. You said, hey, this is what you wanted to hear about. So help us understand how you're gonna take this information and what you'd like to do next.
First of all, thank you all very much for all the suggestions, the discussion, the interactions that you've just had. What we hope to do with these discussions, of course, is to help guide our thinking about how we organize our investigator-initiated research program, so that we can emphasize areas that you've identified as weaknesses or areas where we need additional information or knowledge, so that we can get more of our external research program engaged, similar to the highlights I showed you there, that provided us the knowledge and the wisdom that helps us move the system forward. The second area is there are some areas here that you were discussing that are clearly parts of our intramural activities. And so those will help feed and prioritize some of the work that's going on internally, particularly the area around telehealth care. I stopped calling it telehealth because it's always focused on the outcome as opposed to, I guess, I'm not sure what telehealth is, but telehealth care, because that's ultimately what people are trying to do, is provide care through some kind of digital means. And of course, there's many other kind of platforms. We have a very active group within AHRQ who will take your comments and recognize what areas we have in common as we think about how telehealth care is transitioned into the future of healthcare delivery in the United States. So a very rich discussion, many suggestions and ideas for how we think about how we prioritize where we spend our time and what we do. And I look to the NAC to help us and guide us in making those kinds of decisions, because we have few resources, little time, and a great opportunity to actually make some changes, but we've got to do it now. We can't wait for 2 years from now, 3 years from now.
Thanks for that summary, and it sounds like good next steps. Well, one thing I wanted to call out for NAC members, especially for the new ones, is that your engagement with the NAC is not just during the meeting, right? There's intra-meeting engagement in work that we can work around as well, and including things like a snack or writing up a blog post. So just so you all know, this is not just a, once every blue moon kind of come in and meet. And it's also a lifelong commitment. I don't know if you guys knew that, right? So for the new members, they don't let you go. You stay, even if you're not officially a member of the NAC. So that should be encouraging to you, especially after the discussion that we've just engaged in over the last a few minutes or so. Before I let us go on break, Henry wanted to jump in. So Henry, go ahead, jump in. Oh no, I saw your hand up. Oh, it's back down. Okay, just kidding. So what we'll do is we're gonna take our afternoon break here. We are going to reconvene same time. We're gonna reconvene sharply at 2:45. And I mean sharply at 2:45 Eastern. Okay, thank you. I think it's.
Can everyone hear me okay? I was told the microphone is somewhat hard to hear. Okay, great. Thank you. Good afternoon, everyone. It's really a pleasure and an honor to be here addressing this group and the entire Agency for Healthcare Research and Quality. I speak to policy groups quite often and health services researchers, but I find myself talking a lot more to the investor group because that's where I work now, and I'm actually having a great time because it turns out they need people like us in those rooms. A little bit about me, I'm sure there's a bio somewhere, but I've spent a number of years in the public sector. So started off in public policy at the Congressional Budget Office and went back to get a PhD and a postdoc. So College of Public Health, College of Medicine, and came right back to policy and policy research. So that's where I've made my home for, well, more than a decade. Let's just leave it at that. And my last policy role was running health at the White House Office of Management and Budget for President Obama, which was pretty all-encompassing job, not just because of what it is, but just the ground you cover. You are in that job. I was responsible for domestic health, so you get to see healthcare from a vantage point that's not typically available to the average, academic researcher or policy analyst. I've also spent some years in the private sector, primarily in consulting. So, up to running a large consulting company, but that was still pretty much focused on evaluation, monitoring, looking at large federal contracts. And when you run a company, I ran a large company that was doing that work and ended up taking it through an M&A process as it was acquired by a strategic. That's what, that gets me to Welsh Carson, Anderson & Stowe, which is an investment firm in New York City, focused, I should probably advance my slide, focused on two sectors only, technology and healthcare, which makes us unique in some ways. As far as I know, Welsh Carson is the oldest PE firm focused on healthcare exclusively. So it started in 1979. And we're not big, we're about 100 people, all inclusive of everybody, including admin and other support staff and investment professionals. And so unlike what you typically think about private equity, and I'll go into detail as to what we do, what we get our money and all of that, we're not as distributed. So you have a lot of PE firms And by the way, relative to some large PE firms, we're not that big, even when you're talking about a $5 billion raise, which is what we're doing now, and we'll probably hit it. You have others that raise 20 billion, you know, and have a much more distributed investment portfolio. So not just healthcare, they invest in consumer products, financial services, utilities, oil and gas. And so when you're focused on that sort of in two specific industries, you find that we are smaller relative to some of the largest ones. But I do think that that makes us unique, and that's what makes it attractive to people like me. So I'm an operating partner with a policy background, health services research, health econ. We've got a partner who is a physician, so from Yale, focused on quality, clinical quality, et cetera. We focus on talent. So we have a talent partner. If you're going to invest and run and build strong businesses, having the best talent is a key part of that equation. So scouring the country for the best operators, people who know what it means to run a healthcare business, because sometimes those skills do not transfer from some other sector to healthcare. If you don't understand healthcare, we can save that story for another day, but many people walk in not understanding healthcare and make terrible mistakes with lives at stake. So it's a very competitive world, right? There's not an unlimited number of people or pool of people who we would think of as world-class operators in this space. So that's a little bit about Welsh. Something else that I was just sharing with the smaller group back here that makes us unique is this great partnership and relationship with the Academy, which is here in the DC area. The Health Management Academy is a peer group, if you will. It's an organization of peer CXOs. So think about CEOs, chief executive officers, chief operating officers, chief nursing officers, chief financial officers, the C-suites, and the level right underneath that of the largest health systems in the country. So I think the threshold is 4 billion. That's about right. So the largest 150 health systems in the country who participate in this academy, if you will. And we have a very symbiotic relationship with them. We want our ears as close to the ground as possible when it comes to the provider community, as well as payers. But this is sort of our need, and we want to hear what's happening with workforce, what's happening with technology, what makes the difference, what doesn't. How are you handling any pressures around consolidation? How are you handling negotiations with physician practice groups? So there's a lot that goes into running a large health system, whether it's regional or more national footprint, most are regional. And having sort of a close ear to the ground with this organization is another differentiator for us. We value that relationship quite a bit. A little bit more, again, just sort of level setting here for the group. A little bit more about Welsh. So, and again, there's a Q&A process, so feel free to ask questions. I'm trying not to use a lot of acronyms, but you often hear about LPs when you are speaking about investors or investments. LPs are limited partners. So these are the folks that give us money to invest. And, you know, in our case, I think in most private equity firms cases as well, the groups that are in a position to write large checks for you to invest are pension funds. So some of our largest and most consistent, so 20-year relationships in this case, most are longer, are CalPERS, the California Public Employees Retirement System, the California State Teachers Retirement System, CalSTRS, CalPERS, New York City Employee Retirement System, State Board of Investment in Minnesota, the state of Hawaii, public employees, the state of Connecticut. There's a long list of them. But essentially, they give us, the managers of those 401k funds essentially look at their portfolio and say, how do we want to invest our employees' contributions to their retirement, and how best can we create a balanced portfolio? So you got some, they allocate the vast majority to public equities, right, the public market. And then you've got a minority, really about 10 to 15%, depending on the year, that comes to private equity. And that's where that's our source of funds for investment. largely speaking. And, I think when someone writes you a check and says, we want you to invest so that people who are retiring 10, 20 years from now can actually retire, the expectation is not that we lose money. The expectation is that we make money and help them build out their portfolio. And there, as part of these extensive agreements, we have to assure that we will hit a certain target, right, in terms of growing those pools of funds. And that's what they pay us for. And if we don't hit our targets, investors, they will not pay you. You will not get, the payments that have been agreed to. So and they hold us to account, by the way. So at least with Welsh Carson, again, my N is an N of 1. I have not worked in other PE firms, but there is a strong interest in what we do in the healthcare sector. Many of them know the healthcare sector very well. So when we have our investor meetings, they are coming often as experts, actually. So if you break it, they will know, because we're giving these quarterly meetings, and we're talking to people who certainly understand the healthcare system, whether it's because they've been in that space or have been investors in that space, or they're hearing from their members and their employees, if you will. But they're coming to us expecting that we are building solid companies. So that's what we are doing, and that's what we strive very hard to do. Okay. I'll go very quickly here. In partnership with our teams internally, investment partners, we really do focus on companies that are growth oriented, and not growth oriented in the venture sense. Private equity typically invests in much more established companies. The check size, if you think about PE versus VC, maybe I should back up a second. Venture capital focuses on investments in earlier stage companies, higher risk, earlier stage, smaller check sizes. 50,000 maybe that's more seed round, but Series A's, you've got folks writing checks at that level up to a few million, maybe 10 million. Private equity is, our average check size needs to be 500 million for us to invest at an appropriate cadence. There is no early stage company that can absorb a $500 million check, right? So you're talking about much more established companies. And so growth oriented in the PE space is really referring to, can we expand the sphere of operations for this company? Can we go from 2 states to 15 or 5 or 10, depending on the company? Can we expand the services? If it's pharma, is there another strategy that we could sort of think about in terms of services or therapeutics that we want to develop? So it's much more, there's a lot of time and intellectual capital put into how do we take this business from what it is, which is not a failing business. We're not looking for failing businesses that we can sort of rescue, established and running well, but we think we can make it something more and something bigger and much more sustainable over time. So that's how we think about sort of value and value maximization. Often in PE, I think increasingly so, again, I'm still a student, right? I haven't grown up in this field, but the deal structures are complex. You rarely have one firm only investing in a particular company. So 500 million might sound like a lot. For some of these deals, if you look at the deal value, you're looking, many of them are billions of dollars, which means that there was a team, if you will, like a group of investors, either other private equity firms, other strategic is sort of another company that has resources to invest, and they have their own fund. And so the deal structures can be complex, but again, learning to work across sectors and with other investors when you think about healthcare businesses is necessary. So we are certainly part of that ecosystem, and it's been a great learning experience for me. Just a little bit on, can't see the top here. The global buyout market, I think, is what this slide says. Let me see what it says. I'm sorry? Yes, the global buyout market. I want to pivot and give some context for what's been happening in the world in the last couple of years. Healthcare has comprised about 15% of the total deal value. So when you think about, 1 trillion, that's in 2021, Healthcare is about 15% of that. I think there's a line, I can't quite see this very well, but so this might be deal count. There's deal value and then there's also deal count. In private equity, global buyout is referring to PE. We're not talking thousands and thousands and thousands of deals, right? And I think that's just important. We're talking hundreds perhaps, but bigger dollars. So it's just helpful, which is why I wanted to level set on the types of what the check size might be in PE versus VC. So we went from global, this is North America, and I want to just acknowledge Bain for some of this analysis, a lot of the analysis that went into this. But in 2021, we see that the healthcare buyouts, so healthcare equity PE deals, jumped from 20 to 21. In 21, again, North America, so there's a lot of activity in Canada, because I've lost a deal to a Canadian company, 216. Provider-related services make up the bulk of that. That's the part of the box in red. But you also see, a lot of activity in pharma and a growing number of activities in life sciences. Let's see, I have another deck about HIT, so we'll just keep moving here. Deal value increased significantly between 20 and 21. So certainly interest globally, as well as in this hemisphere when it comes to healthcare deals. It's not unique to the United States, even though we focus on what's happening in the United States with respect to PE activity in healthcare. This slide should say here, provider deal volumes and values rose as practice acquisitions. I think this is about practice acquisitions. It's blocked off on my screen here. They rose as practice acquisitions rebounded and new care models attracted a surge of investor and corporate interests. So thank you. So you'll see, again, deal volume on the provider side went up from 20 to 21. And just to, some of the drivers, I think that, this group would find interesting. Primary care models. If you are on the payment side, CMS is very interested in galvanizing how we rethink primary care. There are a number of models out of CMMI, the Innovation Center, focused on primary care. That's actually been going on since the inception of CMMI. And there are some primary care models that have come and gone. Thank you very much. Primary care models that have come and gone, and we're still building on it. So you see the same level of interest among commercial payers, the same level of interest in MA. And, providers have been very interested in building new provider practices that sort of advance and rethink how we do primary care. Technology is playing a huge role in this. But just also the pressures from consumers. COVID and this pandemic changed in many ways how we consume healthcare services, whether it's by location, whether it's expectations around the use of technology. And it's hard to go back. I don't know that we will ever go back to the way things were. Perhaps we're not moving at the same rapid clip in terms of tech adoption and all of that. But that's certainly a conversation in terms of, what folks are seeing. But yeah, so I think we saw a lot of movement on the provider side in the last year, and I think that will continue. Companies that are looking at specialty practice roll-ups. So you see this in orthopedics. I remember several years ago, there were a lot of roll-ups, if you will. So consolidation among practices. Or when I looked at sort of the list, it was clear to me it was basically any practice that was focused on like the neck and above. So ENT, you name it. That was sort of the flavor at the time. Now you see a lot of consolidation around orthopedics, primary care, less so among OB-GYN. Cardiology will accelerate. And so we're expecting to see that. And again, this I think would be part of a rich conversation. What is happening to physicians who are practicing independently that is causing them to move very stridently towards consolidation and MSO relationships. That is something I think policy world hasn't fully grappled with. And there are some real forces that make these arrangements very attractive, whether it's moving towards an MSO relationship, whether which is PE backed or usually PE, because that check sizes for these large physician practice groups are not necessarily venture, or moving to employment relationships with health systems, right? So I think just thinking about what that foretells is always very helpful. Some examples, I have some logos at the bottom just in case folks are interested, so you have a sense. Okay. Let me use this. It's not moving. I'll use this one. We're having fun tech issues. There we go. Okay. And yeah, I thought this was interesting. So what's happening with healthcare IT? Lots of activity, certainly a jump. Again, jump in the global, in the North American context is from 48 to 75 deals in 2021, which is huge. But deal value at 38 billion. So that's not, these are non-trivial deal sizes. I think driven primarily by Athena Health, which is sort of a mega deal. But Hinge Health, so you see a lot of activity on the tech side. Around musculoskeletal, lots of new companies focused on virtual PT, behavioral health, certainly Noom and Ginger and Headspace merged. So Noom would fall into that category, sort of a psych-based diet and wellness app. Did a significant raise. Ginger, same thing, Athena Health. So, and there are many, many examples here. But I think digital health and healthcare IT will continue to be of significant interest, because to the extent we're talking about healthcare transformation, this is such a key piece of that puzzle. So, what patients are expecting, then the use of real world evidence. There's some, I didn't even list those here, but like companies like Evidation or Aetion. So if you've got these new tech-driven companies that are collecting data 24/7, I don't think that we've figured out exactly, we're not at a happy place when it comes to the use of those data, and the optimizing how pharmaceutical companies and manufacturers can use some of that data to actually, whether it's building better therapies, building better products, or just addressing the needs of a much more diverse and diversified population. So a lot more to do there. And I think this will just continue to be of interest for investors. I have a lot of text here. It's very dense, but I don't think I need to hit every point. Okay, more dense slides. So what COVID did, COVID spotlight, I think it's, most people know this, but from the investor perspective, there's been a growing interest, and I think this will be sustained in alternative sites of care, shifting care from high acuity locations to health anywhere, health at home, increased use of telemedicine. Those two tend to go hand in hand. And of course, modernization of clinical trials, but there's an interest and a need to invest in sort of a even more diverse mix of clinical trial participants. Decentralization of trials is sort of getting at that, so people actually have access physically to clinical trials, the use of real world data. So just a lot going on there. And of course, I mentioned earlier, healthcare provider consolidation will continue to be driven, just maybe changes from year to year in the types of practice. I thought this was helpful, sort of tee up PE focused, private equity focused on more established companies, venture capital focused on some perhaps earlier stage companies. But in terms of big buckets from where I sit, where investors are looking at, health anywhere platforms are very, very interesting and popular. But again, when I think about some of the biggest drivers, it's MA, it's Medicare Advantage, it's commercial payers. It's Medicaid. There's 80 million people is roughly covered in the Medicaid program. So value-based care is a huge driver of where dollars, time, energy are sort of channeled as we look to truly transform the healthcare system. So I've mentioned a number of these: post-acute care, of course, to meet the needs of, again, today's patient, but also to tomorrow's consumer. Tech firms are a big player in this space, tech firms that do health. A number of these CEOs had, especially on the healthcare IT side, have no healthcare background. And that's a badge of honor for them because they feel like the people who've been in healthcare for 20 years have just done nothing but get it wrong and have broken the system. So there's this culture of, we don't want to know about the healthcare system. We simply want to break it, disrupt it, and build something better. Perhaps I'm biased. I'm a healthcare person. Those are some of, I find that if you don't have a healthcare person next to you and you feel that, you are dangerous because you don't know what you don't know. And healthcare is healthcare is a unique industry. It is not like everything else. Another big driver of, I think in terms of where investors are focused on is workforce and staffing. You can't sit in a health system meeting, large hospital system meeting and not hear about workforce and staffing challenges. I mean, that line item alone on every budget went up by more than 100% from 19 to 20, 20 to 21. And health systems just had their worst quarters in the last quarter. It is a significant expense, and it's been very hard to recover. And utilization, if you think about where the revenues come from, ED and others, some other high cost areas or high reimbursement areas from their perspective, those have not rebounded to what they were in 2019. So there's been some real, there's been some challenges, I think, for some of their balance sheets in the last couple of months, but it was exacerbated significantly by this brewing challenge on the workforce side, because that had existed before 19, but then you had the mass exodus and retirement among nurses out and significant burnout issues. And, some, pricing sort of, many of them will call it price gouging from staffing agencies who could charge and did charge whatever they wanted, because essentially from a health system's perspective, if you don't have a nurse to staff a bed, you don't have a bed. And so what ended up happening in many cases, they'll pay anything to keep beds open because they needed to serve people. There's a huge surge. And when that just did not work, they shut beds down, they closed units down, and we still see that happening across the country. So we haven't actually right-sized, and workforce is driving a lot of those challenges. So what you see on the workforce side is not necessarily investments in typical staffing firms, even though that's still happening, and some have come on the market recently, but technology. Can we invest in tech solutions that help you predict surges? Can we invest in tech solutions that help you move staff around pretty seamlessly within a healthcare system so that you're not paying an external or third party? Can we, how much can predictive analytics solve this? Because at the end of the day, you need a human being by the bedside, right? But you see a lot of investments in this space all around staffing. Some of them you have to look closely to see that this is a staffing solution, but that's what they are. Health IT, digital health, I've talked about. Specialty services is also very interesting. A lot of interest in dental. DentaQuest transacted, Liberty transacted. We bought, those are big dental benefits managers, because we know that the extent to which, well, this is my pitch, so I'll probably make, this is about me. I believe that your overall health is tied to your oral health, and that to make this artificial distinction, because the data actually does not support that. The data tells us that one of the top 10 reasons for ED use is issues with your dental health. So we've known that in health services for a long time, but because of the way we pay for health, especially in the Medicare program, which kind of translates to other payment systems, we've got this artificial demarcation, and it's like penny wise, pound foolish, right? So you're saving money, you're not covering dental, but you're spending it all on your ED, which is of course the most expensive, most inefficient site of care. So there's been a lot of interest there driven in part by Walsh Carson. And we jointly invested in a large dental benefits company with Anthem, which is now called Elevance. We are also seeing a lot of interest, I think, in, I mentioned primary care, so ChenMed, CenterWell, which is MA driven. I can rattle off a few workforce companies, but it's just fair to say there is growing interest because this is a complicated market. Obviously, private equity and private capital is one source of funding. I read everything that is written about the role of PE in healthcare. Some of it, I think there's certainly some truth. I think there have been some mistakes and there have been some bad actors. But as someone who's in this business and sits in deal meetings every week and has participated in the transaction, and I do a fair amount of work in the space, I'm happy to entertain notions of other sources of capital. I think if we're thinking that the government will fund everything in healthcare, given what has to happen in healthcare, that's just not possible, and it won't happen. So I think understanding that this is one source of capital, especially for some of the big transformations we want to see happen. But perhaps, the fact that there's very little cross-pollination between researchers, policymakers, and investors is part of the problem. No one understands what the other group is doing. And some of that, the fact that what investors do and how they think about incentives is so opaque, right, to outsiders, I think has been an issue. So that's why this has been a wonderful opportunity for me to come talk to this group. I speak to a fair number. Oh, I thought that was my last slide, but maybe I want to talk about women's health here. That's another area that I think is seeing significant interest, primarily on the VC side. So a lot of those companies in the women's health space are nascent. But there are so many of them: fertility, labor and delivery, maternal and child health. There are so many companies in women's health space that primary care, Tia is a primary care company, Maven, there are so many. They're newer, but I do think that there will be a roll up at some point where there's sort of a bringing a couple of these together, because we see sort of a continuum that will happen, and private equity will probably play a bigger role. Social determinants of health, not a lot of PE activity right now. A lot of VC, again, they're younger, earlier stage companies, but certainly a lot of interest as health systems and payers are looking to do more with social determinants of health data, with the sort of the effort, in fits and starts to do more in health equity space. So I think I have this up here for reference, but one thing we learned in the last couple of months is that there's so much capital out there. I would probably temper that a little bit now, but that's probably changed just in the last 4 or 5 weeks. But if you're a company doing something interesting, it's not hard to find money, because there's just a lot of money in the system. So I think it tipped valuations to the point of ridiculous as far as I was concerned. But I was saying that as someone who was new in the industry. But we'd look at a company and we couldn't figure out exactly what they did that was meaningful or differentiated. And we thought, well, this can't be worth X. But you talk to the CEO, you talk to the founder, they tell you it's worth $1 billion, and they transacted $1 billion. So we've been very conservative and wrong on a number of some of these deals. And but it just kind of tells you the power of private capital in healthcare and how it can drive a lot of what we see in the system. So with that, I think I'm over my time, and we'll be happy to take questions. I'll transition back to Edmondo.
Thank you very much. Very enlightening and great stats. Actually took some of those numbers down. I think we have remotely, I think we have Avi on. Do we want to? Is he on? And can he? He's on. Okay, so let's move over to Avi Sarma to jump in. You've got about 15, maybe 18 minutes.
Okay, I'll try to make up some time here so we can have questions. But thank you everyone for having me. I'm Avi Sarma. That was a great first lead-in presentation, and I think talked on a lot of these trends, and I'm here to focus on that earlier stage and earlier portion of capital investment into health technologies, which the previous speaker talked about quite a bit. Just a quick introduction of myself. So I run a fund called Grill Ventures. We're a global venture capital investment company, and we focus on investing in early stage startup technology companies with a mission to advance dignity, through our investments. And that's kind of a big marketing tagline, but what it really means is we're just trying to invest in companies that are making the world a little happier through their business model. And so that takes the form of education, food and agriculture, energy, transportation, financial services, and also health and mental wellness. So that's an area that we have focused in. So we've invested in the space of health technology. We've invested in companies, everything from some large kind of insurance, revolutionizing insurance type companies that are focused on, data-driven intervention models. We've invested in like kind of an Uber for ambulances type company that went public, helping using data to route traffic for bringing people to primary and intensive care. We've invested in companies that are putting out remote health centers in places like Guatemala and Africa that are fully driven and fully automated, kind of dock in a boxes that kind of can reach people in spaza shops and in other places in the equivalent of 7-Elevens. So we've invested in all kinds of companies. And also in mental wellness, we've invested in companies that are doing things like breath work. We've looked at things like psychedelic investments. We haven't invested there yet. And we've also invested in digital health solutions in companies that are doing patient engagement in a very empathetic way. So that's kind of an overview and an introduction of who we are. And, this is an area that I think it seems a little bit like the Wild West. So I'll talk a little bit about that. Some of the opportunities, some of the pitfalls, limitations of venture capital and funding healthcare, some of the things that we've seen as companies have gone from seed investment, sometimes behind a presentation, all the way through the public markets, and then maybe some insights and opportunities for AHRQ as well. So I can take the next slide. So just some discussion items today. I'd like to start with just generally what's the purpose of venture capital. The previous speaker touched on this, but I can maybe go in a little bit more detail. What role does it play in healthcare innovation? And again, I'm going to focus not on kind of life sciences, but on healthcare technologies, things like applications and deeper technology. What are some of the key limitations that venture capital has? And then I'll spotlight on one of the industries that was brought up before, which is mental telehealth, remote telehealth for mental health care, and then maybe go through some of those opportunities and limitations. And then we can talk about maybe an opportunity for AHRQ in terms of finding and highlighting evidence-backed solutions in the space. So I'll take the next slide. So the general purpose of venture capital is that it takes the early risk in private loss-making startups. So these are early companies, sometimes, again, just behind a presentation, somebody with an idea, a dream that wants to kind of bring together their skill set, has an idea for a new technology or a service, and it basically funds the gap. A lot of times these companies are, they can only dream of getting, private equity type capital. That's very, very far down the line for them. And venture capital relies on significant downstream economic infrastructure and an ecosystem. So usually it's a solution, a service that is coming to the market at a very early stage, and it requires a huge amount of kind of buildup of economic activity. So for example, in healthcare, you might build a billing system or a data system. You need to interact with the whole ecosystem that's been built up. So in theory, venture capital should pay it forward for society in terms of generating a new service and increasing economic activity, increasing outcomes, therefore, resulting in the need for more innovation, down the line. It is an excellent resource for spurring innovation. So you a lot of times have great new disruptive technologies that come out that are reaching people in new ways with new services. But the ultimate goal is to make a profit on the exits of companies and return cash to investors. So it's very basic, share price in versus share price out. That's the concept. And VC investors want to exit. They don't necessarily want to be with the company for 20, 30 years. They want to exit as fast as possible. So that does bring, and I'll talk about that a little bit more, some limitations, particularly in the healthcare space. I'll take the next slide. So what's the role in driving healthcare innovation? So again, I'm not going to focus on kind of life sciences and biotech and pharma, because that's not my area of expertise. But I'm going to focus on things like digital health. So that's things like wearable devices. This is a ring that's a wearable device. It tracks my heart rate. It tracks my breathing. So those are things that are wearables, connected devices. There are mobile health applications, so things that live on your phone that can kind of track what you're doing, deliver services through them. There's telemedicine, so reaching people, reaching people through things like Zoom and other services. And then there's personalized medicine and tools. And this has reached a total of 40 billion of investment in 2021. So as you can see, there's been many investments. They're much smaller in size, but it gets to significant amounts of funding at early stage. So it's lower size tickets, but a larger kind of overall investment that happens. And then there's also health technology that drives a lot of these digital health applications. So that's things like open data systems, identity systems, care enablement systems, and they rely on innovations like AI and machine learning, digital health, connected Internet of Things, genomics, and other sequencing technologies and hardware. So there's a lot of investment that's happening in these areas. It's significant amounts, but I think the previous speaker talked about 50 deals and 40 billion. And this would be, hundreds and hundreds, or if not thousands and thousands of deals that are reaching them, those numbers. And as you can see, there's 15 million as an average check size. So you can kind of see the difference at the earlier stage. And again, these innovations should lead in a successful company to improve quality, decrease costs, or a better experience for the consumers. In this case, for patients or for doctors or health systems or whoever the ultimate end user of the service is. That's the ultimate goal of the service, and then you'll have increased valuations and a greater chance for kind of an exit of the company. I'll take the next slide. So there are some key limitations for venture capital. I would say that I think probably a lot of people here have heard of some of the more spectacular failures, particularly in healthcare. Healthcare is really big and hard. It's a complicated problem. So unlike an application where you're selling something, a product on an e-commerce site or something like that, healthcare, you're dealing with patients, you're dealing with health systems, you're dealing with these very, very hard, problems that are incredibly complex. So everything from the underlying data to the AI models and all of the core innovations to the way you reach people, the design thinking and challenges is incredibly hard. And I've come to the belief that it's like impossible to revolutionize anything in healthcare. I think I share that sentiment with the previous speaker. There's a lot of companies that will tell you they're going to revolutionize like insurance, and they raise $500 million. I've been a part of those investments that, and then they reach 40,000 people, so it's very, very hard to actually build a company and reach the levels of people that you need to in healthcare. And the problems are very hard that I'm sure all of you kind of know about. So for me, the slow movements forward, focus on quality, experience, and cost, that's really what the name of the game is. And you can still build incredibly large companies that are doing this. Another big problem, not just the complexity of healthcare, but you have to build a company. So there could be an incredibly smart scientist or technologist who's building the service. It could be something that relies on AI or data science. It could be a new application. But you ultimately have to interact with a lot of these stakeholders. So I definitely agree with the previous speaker on this. I think I'm agreeing a lot that you need a healthcare person in the team to understand this space quite a bit, because it's very, very hard to build something real. And then the last point, this is an important one for me, is just beware the VC kind of pump and dump that happens. A lot of the cash that cycles into these early stage companies, the valuations mean nothing, and they just kind of want to push as much cash in and out as quickly as they can. And this can kind of get in the way of some of these innovations that are coming through. So you have the marketing side of venture capital, and then you have the actual outcomes for patients, and making sure that one can see through a lot of that self-fulfilling hype cycle that can become quite public. I'm gonna try. I was told not to give specific examples of companies, so I'm gonna avoid doing that. On the negative side, can I get the next slide? So I just want to spotlight mental health care that's been delivered through telehealth as like an example of some of the opportunities that are come from venture capital investment, but also some of the limitations. This is an area that's fairly personal to me because I've experienced my own journey of mental health. And in 2021, a huge amount of venture capital funding flowed into digital telehealth companies to meet the needs of the pandemic. So you had rules changes, regulators changed rules for delivering healthcare services and prescription medication and things like that, direct to consumer. And so you had many companies reach billions of valuation, kind of a who's who of investors behind them in areas like psychiatric care, so ADHD, depression, anxiety, even things like bipolar disorder. You had sexual health as well, companies delivering, prescription medication. You even had companies, and I have friends that have started companies in all of these areas. You even had things that were new areas of like psychedelic treatments, ketamine research and others, where people would deliver psychedelic treatments to people at home with a therapist, and they reached 13, 14 states. So the question that I have as a spotlight in this area is, what's the real impact, on outcomes and equity, given that this group is AHRQ and focused on that kind of area of research. You have, obviously companies that are reaching millions of people now, but do they really need the service? So as somebody who's kind of approaching this with my own, kind of needs of mental health, I don't have the traditional gatekeepers. There are companies now being sued for prescribing ADHD medication just to anyone who filled out a form. In traditional healthcare, that would be something that would have a gatekeeper. And VC and technology can allow, there's a lot of gray area. And then also in terms of the people you're reaching, are these really underserved populations? Does it really have an impact on the overall kind of mental health of the population? I would argue that looking at the data on mental health at the same time as the explosion of the mental health, telehealth, reaching millions of people, the data is that people are more depressed and anxious than ever before. Addiction has gone up. So the question I have is, are these solutions really evidence-backed? Would they meet the rigor of, a true healthcare delivery? So I just wanted to spotlight that. I could, again, talk about specific examples, but I'll avoid that on the negative side. There's also a lot of positives that come out of, these things as well, because you are reaching people in acute need during a crisis time. I'll take the next slide. So I thought I could just conclude with what are some opportunity areas for AHRQ, to actually work with these early stage companies. So I'll, maybe, give an example. One opportunity area is to partner with emerging solutions in these various areas, whether it's in mental health or digital health, to spotlight evidence-backed solutions that have a high impact. So this is a company from our portfolio. I got their permission to use their name, and it's a positive example, so I don't feel too bad about it. So Healthvana is a company based in LA. They use modern technology to make healthcare better for patients. They've done this 50 million times since 2015, and it's a startup. It's an early stage startup. It's not a one of these companies that's incredibly large. It has a very nimble team. It's a technology focused platform. And they basically do empathetic patient communication, and they're a very focused service between a healthcare provider or healthcare system and a patient. And they were doing this for many years in HIV for the AIDS Health Foundation across the country. And then when COVID happened, I actually spent a lot of time with the CEO. He was like, I do this service incredibly well. I've done it. At that point, it was millions of times. Let me take this service to health departments and see if I can't, break through some of the clutter with delivering, health test results to patients that are in need. And they've done that now in 20 states with cities and states. It's a very, very focused solution. It's a digital health solution. And they're able to then start giving other education, opportunities for other appointments, opportunities for delivery of additional tests, additional services, just from that very specific solution that they had. And this company was funded by venture capital. It's now very profitable. They didn't let us invest again when we really wanted to, when they were exploding during COVID. But the question that I have, I guess, for the group or, for future discussion potentially is, how can a group in the government support with evidence on the outcomes and on the equity? So for example, Healthvana's, when they did a LA County test site, 67% of patients came from communities of color. So this is a company that's hosting a huge amount of data. I think the previous speaker also talked about, do we trust these companies with data? I don't know the answer to that. I personally, a lot of times don't, but maybe with the partnership with the government, to understand who are the good companies that are really doing positive work with this data and then spotlighting them, making them more of a standard. That could be a good new form of public-private partnership. So I'll stop there. That's kind of all I have. So hopefully that was informative, and I'll take any questions.
That was informative. So thank you for both actually for those presentations and really framing up the conversation and having an opportunity to both dig in a little bit on the PE side as well as the VC side, similarities and differences, and for the opportunity to kind of think about the role of AHRQ and quality and equity and some of the things that were brought up in the last slide that Ali had there. So really good conversation. I have a whole list of questions that I'm not going to start with. So I'll hold those because I already see some hands up, and I want to get to some other members of the council. So let's start with Jaji.
So first off, thank you for the presentation. It's great, and it's really in my field. I'm the dean of the School of Biomedical Informatics, which means medical AI, data science, technology, everything. So in addition to education, we do a lot of research and development. We do product development, AI, medical AI. One fundamental question we have been trying to address is that for complex healthcare, especially for complex problems, it's a vertical problem. You have to be insider in the healthcare system, in the hospital clinics, in order to solve the problem. But most of the technology companies are trying to solve a simple problem at a scale. They can put a watch on everybody's back hand. So they can solve small problem, but that's not going to address the fundamental healthcare problem. Okay. So one question is that, especially from the investment community, do you think there will ever be a Google-like company, Google for healthcare, that's going to take care of everything and solve all the problems down the road? And potentially the biggest healthcare company in the future is going to be a technology company. So that's number one question. And number two, a lot of the healthcare issues that we are trying to address, especially from AHRQ perspective, are actually prevention. It's not really treatment. So if you pay a lot of attention on the prevention, a lot of things may never happen. So that's going to be a more fundamental challenge for the tech companies. But again, the bottom line is technology is, I like technology, that's what we do every day, 24/7. But we also are thinking about the potential limit. And everybody's super excited. But again, as you mentioned, both of you, there are some risks up there. The question is, how far can we go with technology in healthcare?
Who would you like to ask the question to? Sorry.
Yeah, go for it. You can start.
Sure, I'll start. It's actually two very good questions. I'll take the first one. Will there ever be a Google for health? Well, Google has tried, and Google could not build Google for health, right? It's still it's an ongoing work in progress. I say that tongue in cheek, but the real answer is that the problems in healthcare do not rest entirely on data or technology. It's the problems we have in healthcare are multi-pronged and multidimensional. So you take a typical oncology patient, a typical cancer patient. I'm sure there's some cancer and oncology researchers in the room. Even with the best technology, you're in a major cancer center and you've got all the robotics in the world. And so tech isn't the issue. And every data element that can be collected on you is collected. So that's not the issue. What ends up being the sticking point is, can you get the appointments you need when you need them? You're infirm, say if you've got advanced stage cancer, you're pretty weak. You've got an elderly or older patient, older family member helping you navigate just the complex in the place. Can you have your appointment on the 4th floor? Can you have them all on the 4th floor? Do you have to figure out a way to get to the 8th floor? They come down to mundane things like that. And do you have a navigator, someone who can help you navigate the system, help you get your appointments, help you schedule whatever operations you need, follow up, the necessary post-acute. And you find that just the sheer fragmentation in the system when you have to interact with the healthcare system is a nightmare for even people who know the system, let alone lay people. So Google isn't our solution. I don't know. I mean, unless Google builds something else, it's hard to build a technology solution to solve everything. I know we're picking on Google. Let me pick on another one. Amazon just bought One Medical. That deal was just announced today. I think a lot of people are betting on primary care being the solution to a big chunk of our problems. And I think Amazon being a tech company and having tried with Berkshire Hathaway and JP Morgan, and Haven did not succeed and really imploded spectacularly. I'm free to name whatever I want, so I'm gonna name them. I think we've tried, like we've seen some real attempts that have not produced much. Apple just put out a 60-page dossier basically saying, putting a stake in the ground that they are a healthcare company and they're tech. And I think they had to do that. And they're doing that because they think that they've been discounted. But they were the first tech watch to get through FDA clearance, which is a pretty big hurdle. So I think we see a lot of tech companies making moves in this space. The role of primary care, the role of evidence development. I mean, to have this conversation in PE room, which is what I've been doing, is funny, but fun. Developing the evidence to support some of these advancements so that we actually can prove to ourselves that we've built something meaningful in healthcare is the next level question, but it's an immediate one. Avi?
Yeah, I mean, I could just say I agree with everything almost that you were saying, but I mean, for me, like building any tech is incredibly hard to build and get a company to market. Even for simple problems is very, very challenging. That's why you see so many startups fail. So many startups have great ideas, but it's complex to get it actually through the innovation process to the initial customers to the market. And now when you add in the fact that those are simple problems, Google's problem that they were solving was they were indexing web pages using, scraping and, early machine learning to count words, basically. That's what they were doing. And now you're taking like the human body and human psychology and, all of these complex pieces, and you're saying one company is going to solve all of that stuff. I think it's a much, much, much bigger, challenge. So I think what will emerge is just a lot of very, very good solutions to specific problems. highlighted in the right way, that, and there's a lot of great work happening to solve specific problems. And then I think above that, there will be some, as interoperable kind of general, more general purpose things that and layers that come that, kind of organize these systems into services, platforms and things like that. But, I don't think personally that any one company is going to solve, the problem of healthcare. If one company solves one problem in healthcare, they're a massively valuable and successful company that will be there for a very long time.
Thank you all. Come on.
Thank you. That was a great and very informative presentation. I have a question, more of a curiosity question. I mean, you talked about the role of quality outcomes, safety, particularly Avi in your presentation, and of course both PE and VC being disruptors in the field of healthcare and trying to come up with things that hopefully will benefit healthcare down the road. The question is related to when do folks start thinking about quality outcomes? Is it more as a hindsight thought, or is it more of a proactive type approach where they're starting to think about it at the beginning, or is it more at the end? The reason I bring that up is, what do you see? I mean, with your experience and expertise in these areas, where do you see AHRQ playing a role in terms of trying to define these? And hopefully at the beginning, granted, they have their own agenda and priorities in terms of what is it that they want to be accomplishing. So just curious in terms of your thoughts related to those.
Yeah. Are you asking me?
Yeah.
Okay. Yeah, I think that the kind of the multi-part question you had, I think it really depends on the founder of a company. So our biggest mistakes we've made in investing in companies have been, understanding the motivation of the team. And is it a motivation to use certain words to raise money? And what, do they really care about the impact? And particularly as someone who's involved in investing in companies that are trying to make the world a little happier, there's a fine line there. And you see that in healthcare too. And I think there are a lot of examples. And I could go through a few where we had, companies where people were excellent operators and knew how to kind of manipulate the system, but then the impact was very low. And then companies like the example I gave where they really cared about improving patients' lives. So I would say it really depends on I haven't figured out the magic bullet for understanding, people's psychology and founders, but that's what I would say is the biggest determinant of whether a company, continues on that mission is the nature of the founder and why they're doing something. And then in terms of AHRQ's role, I think that the earlier, probably the better, because, a lot of times a lot of forces will come that can lead a company in many different ways. But if there is a channel to kind of spotlight the innovation early, highlight the work, show how, they're evidence-backed, the data points on what they're really doing. Personally, I would love to see that at an earlier stage because it will help everyone in the ecosystem separate the kind of the noise and the real work that's happening out there. Because even if it's just 1 in 10 companies or 1 in 100 companies that's really focused on outcomes, if that can kind of be brought out to the market and tracked over time, I think it'll open up a lot of opportunities. So I would say that companies can start collecting data very early, post like when they bring the product to market. So if there was some sort of avenue at that point, obviously you need quite a bit of data and staying power to get any meaningful studies. But I hope that answered the question.
I want to push it a little bit more, and I want you to kind of jump in on this. So one of the things that I've observed in this space is that you'll have companies, especially the early stage companies, who actually can reach some pretty hefty valuations without any evidence that their intervention truly works. And so, what's the role of an evidence generating body and somewhere in there intervening on that. And how do investors how are you guys even thinking about that, right? So, and one way to get around this one is investors, not present company excluded. Investors often don't know enough to know to push them on their evidence, right? That's one of the challenges. But another approach is just go straight to the consumer, so you can just avoid all the other processes that require that you actually have some kind of quality, check or something. You just go straight to consumer, and you skip a lot of that stuff. So I'm seeing a lot of that. How does it help us understand how are you as investors thinking about that?
So, I mean, a lot to unpack. And I think it depends almost on the company, the type of company, and the stage of the company. But the point you made, the points Kanan made, that certainly I would agree with. Valuations at times are completely divorced from real value. From again my perspective, but we've had a few examples, sort of bear that out. And so, but I do think that it is, for some of the earlier stage companies, let me preface this by saying, it is when you sit in front of a pitch and listen to founders and their management teams make a presentation, if you are not a well-informed, discriminating listener, you will buy everything they sell you. They are first of all, they believe in what they're doing. They've often spent years and sacrificed a lot in their lives to build that company. So they believe it. They are not researchers. So the level of interrogation, the academic rigor that you would bring to outcomes related questions that's not how they think about evaluating the quality and the value of the business. So just, I think, appreciating that anyone in this room would come with a different set of questions, right? To think about the value. But it takes having someone of this ilk here in the room to at least ask some just first and second order questions around, can you just show, or what data are you collecting or will you collect to demonstrate efficacy and effectiveness of whatever this is? Often that is missing. But what you have is a well-meaning team, and quite frankly, investors who probably have an interest in not just investing, but in the solution itself. And that's what I was saying as speaking to intentions. There's a lot of good intention that simply don't materialize. Now, that's sort of a lot of early stage companies. I think the other point I would make is not just efficacy, but just engagement. So think about some of the mental health apps. Often large employers will sign contracts. And so when you go look on their websites and they say, we serve 50 million people, that's true. That's the denominator. But if you ask a second order question, of these folks, how many have you engaged meaningfully in a consistent manner over 6 months? Either they know, but they will never share that with you because it's minuscule. And so then the question so it's not just, is this effective for that small number of people you reach, but just the access question itself, how meaningful is this? So it's hard to get at quality data. It's really hard to get at quality data because you don't have quality measurement people in the room. Now, let me sort of speak to Walsh and the way we think about this. We think about this a priori. We are really, because again, you're not putting hundreds of millions of dollars in something you don't know. The challenges we run into are just the infrastructure for data collection, the standardization, and this is where AHRQ comes in, the standardization for what is quality, what is high quality for this company. Quality is everything and nothing at the same time. So what you find in the marketplace, and I'm being a little bit glib, but that's essentially what you will hear in some settings. Net promoter scores have taken over as a huge indicator of quality in the business world, because it's the one thing everybody understands and it's measured in a standardized way. And yes, on the provider side, ED visits and that reduction is important, but that just doesn't apply to every company. It's hard to compare apples to apples. So that's another important data point, I think, for AHRQ and where AHRQ can play more.
Next up, Yanling, I saw your hand up.
Yes, thanks for the presentation. I have a question, maybe two questions. First one is that, we have a subgroup discussions, and every time in different care settings, the coordinated care and team care all come up. That is very critical to provide quality of care and safe care. So I'm just curious if your insight on developing this high tech and technology to to improve access care or even quality of care. What do you envision this to integrate into the coordinated care rather than the silo? Company A develop technology, gonna collecting data, doing test this type of or diagnose disease A, and then company B develop different technology to evaluate mental status, but then they all ended up in a silo, and then they're now integrated like a medical records integration, medical team integration into the existing patient care system. So I just wonder what do you have any insight on that?
And let me push that to Avi first, and let me add to the question at the risk of detracting a little bit from Yaling's. I don't want to do that, but so speed, especially for these early stage companies, speed to market is a big issue, and so often they are bypassing some of the challenges of healthcare, which include integrating into the actual workflow of a provider system, for example, as Yanling was describing. It also means, like skipping, generating data and outcomes and those kind of things as well. So Avi, how do you think about that for some of these companies where they haven't integrated into the workflow, or they're kind of point solutions that stand alone in an island? What does that look like for you guys?
I would probably say that it's much easier to build a solution that just focuses on doing with technology, focuses on doing one thing and one thing very well. So if that's patient communication or a remote health visit, just doing that is incredibly challenging. I think I've said that a few times. So it's much easier to get to market with a solution that is focused in a way. However, that is one of the big problems with integrated care, and kind of also like time horizon of care. A lot of companies that are just trying to reach a consumer, for example, with a service, are worried on the cost of customer acquisition and reaching people with marketing, bringing them onto a site or onto a program, but retaining the patient and adherence and care that takes into account their broader medical history and all their other providers and all of those things. It's not this, kind of not in the focus of probably a lot of these early stage companies. And then they get into a lot of problems. There's a lot of up and down, where you subscribe a lot of people, but then the care quality decreases over time. So I would just say, maybe if that's my answer from the perspective I have, but I think, our other speaker probably will have a lot more on this because of where she invests into than me do on the early stage stuff.
I think, again, it depends. Integration is something we're starting to see essentially demanded by health systems. It takes a lot to, Avi's right. It's hard to build these solutions, even if they tend to be pretty discrete, solutions. But that aspect of them is inconvenient and expensive for health systems. So we're starting to see, again, at more established levels, if you will, a demand that this really be well integrated into the workflow. But again, because this is healthcare, you've got health systems that themselves are not integrated, they're technology solutions. So anything new is really new, and it just feels like everything is bespoke within the system. it's expensive to buy, they're expensive to maintain. And I think just expensive to sort of to make, to sort of keep that going. So it's a slow process. There is no revolution as Avi said, in healthcare. You hear that every day in pitches, but again, if you've been around for a while, you've seen lots of revolutions not materialize. So it's a hard one. But I think Yan Ling raised the question. It's a very good one. We're still struggling.
Can I give maybe a quick example of a company that is doing something interesting? So in metabolic and obesity, it's a disease, and some of the new therapeutics that are coming out are very hard to get prescribed. It requires a massive amount of workflow in a physician's office and insurance and the pharmacy and all of this to get the actual therapeutic prescribed. Yet you have people struggling with obesity who want this medication. So even if you come to the doctor, it kind of can take you a very long time, or you don't get the prescription. So there's a massive amount of like integrated care and workflow challenges. So there's a company that I know of that's focused on this problem with tech. It has a patient interface for medical provider. It has obesity kind of nutrition specialists. It has kind of prescription, tools for the doctors to write prescriptions all the way through the pharmacy. It's a very early stage solution, but it's a kind of an integrated approach with a lot of the different workflows built in. But this solution, the thesis on the solution took about 2 years for this all to kind of come together, all the way through billing and everything else. And it's at a very early stage. It's very risky. You could be shut down by any number of things like, insurance policies and things like that. So, every time you go out of one particular problem and you go to multiple problems in one solution, it becomes, infinitely more challenging to build something that works and provides quality of care to patients. So.
Thanks for the answer. Just a quick note for the council and the folks on the call. We're into public comment time, but we didn't receive any public comments. So we're gonna roll through a few more minutes into this conversation through the public comment time. Next, I had Andy on my list next up.
Thanks. It was a great presentation. If you think innovation in tech is slow, it takes a year to get a grant, enough a year beyond that to get results. How does that work with the pace of the companies you're working with? How could AHRQ get funding to researchers in time to be helpful? Because often by the time the grant has arrived, the tech has evolved past what you wrote it on.
It's a very good question. I think the collection of evidence, so evidence development shouldn't necessarily be tied to funding from people like me or Avi. So to me, those are sort of a different thing. I think if you've got a solid health services researcher, or you can contract out of that work, they should be talking to AHRQ as soon as you can claim you serve a good number of patients, enough to go to market for any level raise. You should have some data that says, yes, we can, these are the outcomes associated with our product or treatment or, whatever. And I think the challenge, I was never funded. I've written a number of NIH grants. I was funded throughout by the NIH, so it's probably the same. But I think it's that pace. It's understanding that this is not a university, it's not a postdoc university, a faculty member. This is a company. So how do we tweak our methods? How do we tweak our systems to accommodate just a different set of actors? Not in any way that would threaten the validity of the studies, but how do we sort of just flex up or down depending on what's needed to make sure that we generate evidence from a lot of these companies? Because I think, one thing I say to folks, like it or not, healthcare is not just NIH and AHRQ and CMS. There's this huge ecosystem that essentially explains 20% of the economy. And we tend not to know what each other is doing. So, yeah.
Very true. So, Patrick, you were.
Okay. Right. So yeah, so I'm going to, this question is primarily targeted on the private equity side, perhaps because it's been more controversial. But I can see how, for pharmaceuticals, for devices, for IT services, private equity can really kind of add value to the system to bring in a lot of resources rapidly in a way that moves something to scale more quickly and also benefits retirees or future retirees or other investors. I have more trouble understanding what's going on the provider side, on the healthcare provider organizations, where, of course, it's traditionally been largely a nonprofit sector. And what I see a lot of, but maybe that's influenced by what's in the media, but what I see a lot of is emphasis on generating more revenue rather than actually improving the provision of services in a way that improves population health outcomes. So obviously, I'm referring to these private equity deals that look like real estate deals where they're leveraging the property on which the nursing home or hospital is built and then creating some kind of leaseback arrangement that adds value for investors, but it's unclear how it does anything to help patients by just loading more debt or higher operating expenses on organizations that then are unloaded. Or concentration issues. Obviously, there's been some criticism. I've done some work in antitrust, and many of these deals sort of fall under the Hart-Scott-Rodino thresholds for filing for antitrust review. And yet by the time all these roll-ups happen, wow, you have a really big organization that has a significant market share, enough to have an influence on prices. And then, there are the issues of how we influence physician behavior as a physician, provider behavior to generate more revenue, admitting patients who don't really need to be admitted to increase revenue on the hospital side, self-referrals, borderline fraudulent billing, essentially upcoding mechanisms. These mechanisms have already existed. So we know these mechanisms exist in the nonprofit sector and are used by nonprofit organizations. But when I see private equity coming in, it makes me wonder, what do they see as the revenue opportunity there? And is that actually going to benefit patients? So I'm curious, what your thoughts are about this, given your, background in health policy and in the Obama administration and so forth. How do we ensure and how do we collectively build a research base to better understand when public policy should encourage private equity and when public policy should perhaps create some barriers or create some checks and balances?
All very fair questions. Tough, but fair. I would, let me start by saying that private equity in healthcare bears some responsibility for a lot of the narrative. There has been, and I say this as someone who's new, I'm still new generally, but I came into PE as a health services research and health policy person. I was stunned by the fact that there's no data. So it's not just that there's no data that academics have access to, which I thought was the main issue. It's not an industry activity. And so those conversations have begun because it's hard to counter the narrative with anecdotes, which we have, and I've seen a lot of. We need outcomes data, we need economic data, and other types of data that you might ordinarily submit to a congressional body under a subpoena, which has happened quite a bit for obvious reasons, and you've pointed out some of them. So I think it's fair to say that there is a need for information that explains what what investment outcomes essentially, what are the health outcomes associated with investments. You said something interesting because I hadn't heard anyone really phrase it that way, real estate deals, which is how I think about a lot of the nursing home deals that went terribly south in PE. And Avi, you are spared from this conversation because this is squarely a PE issue. These were, because I read them, I read all those articles and was just as, stunned. My dissertation was on nursing home care. So this is an area I know very, very well. Some of these actors had no business in health. They had no business in healthcare, let alone some of the most vulnerable populations in the healthcare system. And the results spoke to that. So I think there was just some unfortunate decision-making because it was ill-informed, over leveraging, because again, you get in and you don't know how to get out of it. And you see sort of this cascade of problems and overload the company with debt, and then and nothing happens. The last thing you want to do, if you know anything about nursing home residents, is to decrease staffing ratio. That just cannot be enough. It's not a solution. It should not be on the set list of solutions. And we saw some of that happen many years ago. Smart PE investors in healthcare will not go into any business like that without knowing exactly what they're going into because they understand the complexity. And I think because of the number of PE firms that have been burned, again, with all the right intentions, but just didn't understand what acuity really means and how it differs from the hospital setting or other PAC settings, I think there was just a lot of lessons learned there. I can't speak for the whole industry because I don't represent the industry here, but I've been in enough conversations to know. We're starting to see some of that in behavioral health, institutional and residential care, where more recent, sort of errors have occurred that quite frankly, because there's a spotlight on private equity, they tend to be metastasized, right? They tend to sort of explode in the press. I think that policy makers don't understand PE, and pretty much anything you read in business press, health services research, or just academic press writ large is negative. It's actually really hard to find anything that says that PE is good in healthcare, which is really unfortunate because so much that has happened that is good in healthcare and the business of healthcare has happened because of PE capital and investments. So the FTC, the Consumer Financial Protection Board, CFPB, I think is the acronym, and a number of others, and some congressional committees have started to ask more questions around if this physician group gets rolled up and it's this multi-state group, what are the implications around antitrust and anti-competitive behavior is spurring that? I think, quite frankly, a policy question that often does not get asked that I think about is why are these arrangements attractive to physicians, right? So because it's not a situation where if you offer it, they will come. If physicians were content with the standard and solo practice arrangements or the small practice arrangements, and that was working and the payment system was facilitating those arrangements, there would not be what we see in the marketplace. And that's a question that rarely gets asked. And the reason, one of the many reasons is it's really hard to do value-based care when you're a solo practitioner or a two-person practice. You don't have the cash, you don't have the resources to build out the kind of technology you need to build out in order to serve your patients and compete. Quality measurement is very difficult because again, you need capital, you need resources to do that. Pretty much anything and everything we expect to see as part of healthcare transformation is virtually impossible when you just look at the standard physician practice. So how do you manage all of that? The operations that you need to back that and hire non-physician staff and other staff, et cetera, is that capital has to come from somewhere. That's not a government function, in my view, and the government hasn't said that it is. So there are market forces driven not just by the payment system, but by just how healthcare has changed, that makes these arrangements that are, PE backed primarily, very attractive. Now, does the FTC have a right to ask some of these questions around anti-competitive behavior? Absolutely. And I think, again, I'm a policy person. If I was in government, I would ask every last one of those questions you just asked. And I think that they're warranted. The other issue you raised, I have strong views about nonprofit hospital systems and whether they're like what makes them nonprofit other than the fact that we say that they're nonprofit. Many of them have venture arms themselves and they invest because they're looking to create solutions as well that serve them. So these are not neat sort of good actors and bad actors. It isn't laid out that way. They're very complex with lots of explanatory factors. And sometimes we shelve some of those factors and focus on others. But I think, again, there's a lot to unpack there, and I'll stop because this can go on for.
No, but it's really great points. What I'd like to do, I'm in my time now, and so I will use my time to wrap this conversation up. And how I'd like to do it is I want to give each of you 30 seconds to wrap. I'll start with Avi. 30 seconds, a wrap of what you really think the NAC, kind of your last kind of departing comments on what we should know from this conversation.
Yeah, I mean, I learned a huge amount from this conversation, so thank you all. I think whenever you have capital incentive, it's designed to be efficient at making money for the people that invest capital. Healthcare is, in my belief, is something that should be about improving people's health and their lives. And those things will always be clashing, but also there's a lot of advantageous things about having private sources of capital. So if anything, AHRQ, for consumers, so the people whose lives are trying to get improved, or for providers who are under stress, or, so many different people need advocacy. And so I think that AHRQ, and research data, truth and data, kind of transparent data, always shines through and has an impact, even if that impact is not, immediately felt. So I think that could be a role as an advocacy body. Thank you.
Thank you. There's 30 seconds.
Avi said what I was going to say, so I have to quickly think about a different point. I think I agree with everything he just said. There is a natural tension between the profit-making motive and the human services side of healthcare. But I do know that the two can coexist. What I do think complicates the matter is when policymakers assume that there is no profit-making motive in healthcare, because that's just not true. It's a digging our head in the sand posture that is unhelpful, because the government and policy actors cannot solve everything in healthcare. So what does that mean? I think bodies like AHRQ and others in the federal and state governments, quite frankly, should be inviting of companies, healthcare companies, to not just understand the businesses and their incentives, but to think about what structures we can create on the public side to get what we need to make better policy, specifically data and information, understanding the incentives so that if we need to design and create policies that better serve the needs of the public, we would be better informed and better equipped to do that. I think the silos have been very unhelpful.
Thank you for those summaries and for your engagement here. Really appreciate it. We're going to move into our chair wrap-up time. And here's going to be my approach today. I do something different every time. So for today, here's what I'd like to do. And this is going to be an engagement. And I know it's at the end of the day, but it's going to be an engagement exercise for the remaining members of the NAC who are not on their way to the airport. Thought exercise, and then a little bit of commentary. It's been a very, very robust day of conversation. Is there any possible way that we can draw common themes between our new snack on health equity, our quality and diverse care settings conversations, and the role of healthcare investment in capital markets in healthcare. Is there any way to draw lines between all of that in a way that summarizes our day today? It's not a rhetorical question, by the way. So just take a minute or so to think about that, and then jump on with some Zoom hand raises so we can wrap this day up. We've only got 9 minutes, so let's do it quickly. I see some hands going up. Saf, I'm going to start with you.
I mean, this is such a huge and important question. So this is a paltry first shot at it. I think that the last conversation highlights the promise and the perils and the limitations of the production model that PE and VC have for answering certain areas of needed innovation and inquiry, in particular, things that are requiring of integration, collaboration, partnership, relationships over time, community participation, inclusion, and are not, narrow technical solutions, are really, certainly for VC, but also for PE funding, not really akin to pathways that they can adequately fund their way into solving that problem. And there's a deeper issue, which we didn't get into, which is that many of the LPs, the pension funds that provide the source of capital, have set up a dependency of making a lot of money off of the essentially inefficiencies is a nice way of putting it. Brokenness is an accurate way of putting it. You can call it the 30% waste, you call it whatever you want, somebody's salary, and they're going to make a lot of money, and that's totally within bounds and mostly legal, except for the stuff that Patrick talked about. And the question is, do they want to be dependent for their workers' 401ks on business models that actually perpetuate the brokenness and actually the high costs of a healthcare system that are suppressing wages and wage growth for their own employees? So that's kind of, it's almost like the tobacco deals that were signed. And full disclosure, I used to be a tobacco control researcher. So, that was a bit of a Faustian bargain. You signed tobacco deals between attorneys general and tobacco companies that make states for many decades dependent on tobacco revenue. And so it's not so easy to start making the right policy choices on reducing that burden. So that's one area. For the health equity, I just think about the fact that this is where AHRQ and AHRQ's partners and ways of knowing and doing to improve how we implement research findings, how we go from breakthrough innovations to follow through innovations. That's where AHRQ can really catalyze important convenings, partnerships, conversations, and funding to get at the real thorny, important integrated relational equity problems that I don't think the market alone can solve.
Well, that was a pretty good swing for the first. That was pretty impressive, and I love that last point of and Avi had mentioned as well. I think where the idea is that AHRQ has a convening function potentially here. And so we should be thoughtful about who we're convening, and maybe a little bit more broad about the diversity of the players in the market that we convene as we accomplish the mission, right? So I love that. Melinda, you're up.
Well, that was really eloquently put, and I will not try to reproduce any part of it. Thank you, Asaf. I will only add to it by saying that there was an interesting discussion about the role of government in making capital investments in healthcare. And I would just point out that we invested far more than $30 billion in health IT infrastructure as part of the Recovery Act. We invest, coming up on the order of, $2 trillion a year of government spending. And we do subsidize all kinds of things that are really human capital investments in healthcare through graduate medical education and the like. And so if we are thinking about how to direct private equity investments that would complement the already massive government investments, we should think about how to do that carefully. And there may be ways to do it that emphasize, for example, equity or patient-centeredness. And we shouldn't put that off the table.
Great points. And tying a few different threads here. So appreciate that. Patrick, your hand's up.
Yeah, I think, I mean, just to build on previous points, the line between these things to me is that the American healthcare system is underperforming. It's been underperforming for years. And when I say underperforming, I'm talking about population health outcomes. I'm talking about the value that we get for the spending. Obviously, I'm talking about how we compare with other national healthcare systems in other countries. So our system is underperforming. And what we've discussed, the issues of equity and disparities, are a manifestation of that. The gaps in healthcare quality measurement that we discussed this morning are linked to that, identifying priority areas. And obviously, as Melinda pointed out, bringing private capital may be helpful, but if the focus is on revenue enhancement, it's unlikely to be helpful because collectively the healthcare system doesn't need more revenue. It needs better output for the revenue that it receives. So, so there's a line between these things. Thank you.
That sounds great. All right, so we've got 3 minutes, so we've got about 45 seconds per person coming up. Susan, you're next.
I agree with what everyone else has said, and I'm going to skip.
Thank you, Judgy, you're up.
But this has been an incredibly productive and thought-provoking meeting. Thank you to everyone.
All right, so here's my 30 seconds. Thomas Friedman wrote a book called The Earth is Flat. His technology is changing a lot of things. I hope technology is going to make healthcare equity disappear.
Outstanding. You're gonna close us out here. Kamal.
I did my 575 haiku. Health equity now requires payment reform and unique partners.
Wow, she actually put the thread into a haiku. We're gonna close out with a haiku, and I dare you to find a NAC meeting that's been closed by a haiku before we're done here. And with that, we adjourn. Thank you.